and then we will see how to handle.
Can you up start kar?
I think Louis Borba is not around, if I'm not mistaken. He is not joined.
Yes, sir.
Louis.
आप broadcast कर दीजिए, रोहित.
Okay, sir.
Yes.
Sir, we are live on YouTube also.
Yeah.
Yes.
Okay. Thank you. Thank you.
We can hold on for a few more minutes because it is not yet time. Mike, you don't have to operate, right? Or you also have to go for surgery?
I'm in clinic today, so I may step out a couple times just to kind of see a patient, but yeah, that's about it.
Okay. So you also enjoy the lectures, my dear Mike?
Well, yeah, looking forward to them. It should be great.
Varnan? Unmute yourself.
Yeah, unmuted. Yeah.
I think let's begin maybe.
Fine. Okay, sir. Yeah.
Varnan?
Sir. Yeah.
You want to introduce Walter so
Yes.
that he can start.
Okay. Good morning, good afternoon, good evening, dear friends, and warm welcome to all of you to this webinar where we hear the masters in the next chapter of International Skull-Based Virtual Summit Series, which is organized by Professor Atul Goel, who is a famous skull-based surgeon and also a CV junction surgeon and a neurosurgeon par excellence. So I welcome you to this webinar, and without any more delay, we shall welcome our first speaker, Professor Walter Jean, who is the professor of neurosurgery and also the director of skull-based surgery at the George Washington University. So welcome, Professor Walter.
Thank you.
I would like you to start a topic, which is the use of virtual and augmented reality for optimization of keyhole approaches to the skull base.
All right, I'm going to go ahead and share my screen now, if I may. So can everybody share my screen, see my screen?
Yes, yes.
Okay, wonderful. So thank you for the invitation, Professor Goel, and to all the other organizers. It's an honor to be here this morning and your afternoon. And today I want to talk a little bit about keyhole surgery applied to skull base and the use of advanced technology for it. And my only disclosure is that I'm an occasional consultant for surgical theater. So let's talk about the keyhole concept. I think it's pretty well known what that all is about nowadays. Of course, it was started with the seminal work by Axel Pernetsky and his team in the 1990s in Germany. And out of that, he produced two very important books that are now really Bibles for the keyhole concept. And of course, others have taken on this banner and advanced the technology and the techniques after Dr. Pernetsky unfortunately passed away very young. And of course, Dr. Teo's book is a major contribution to neurosurgery, and as well as my friend Jim Evans is as well. This quote from Charlie's book really caught my eye the other day, and it says that all truth passes through three stages. First, it is ridiculed. Second, it is violently opposed. Third, it is accepted as being self-evident. And I think we have reached the self-evident stage finally with the keyhole concept of neurosurgery. The main tenet of keyhole concept, of course, is that we're completing the surgical goal safely with the least amount of tissue damage. That's the whole basic concept of keyhole surgery. And let's break that down a little bit. Completing the goal. It does not mean changing the goal or truncating the goal or altering the goal. It is by completing the same goal you would complete with other ways safely. It has to be done safely without causing problems or neurological deficit for sure, compared to other techniques. And tissue, the least amount of tissue damage that not only applies to brain, but of course it applies to the soft tissue, to bone, and other tissue as well. So all tissue when it comes to keyhole concept. And of course, I'll show you this slide that Charlie likes a lot as well. And the whole alteration is from big openings to a small target. We are really using a small opening to a wide space deep inside the skull. Again, a different tenet of this keyhole concept. There are four corridors that are used by the main keyholes, and the keyholes are really the openings to these corridors. The anterior corridor is accessible by the supraorbital keyhole, the lateral corridors by the mini-pterional or subtemporal keyhole, the posterior lateral corridor by the retrosigmoid keyhole, and the posterior medial corridor by anything from a suboccipital to a midline keyhole in the posterior fossa. Those are really the four main corridors, and there are four main keyhole openings to these corridors. And then, so now we're going to leave that aside a little bit and talk about the technology, augmented and virtual reality, and how it applies to keyhole surgery and improves it. So when I talk about augmented and virtual reality, I really mean this technology here, turning ordinary CT scans and MRIs into manipulable, computerized, three-dimensional images that you can turn at any angle and manipulate by drilling, erasing, altering. And these are patient-specific 3D models. Okay, so you're taking patient-specific MRIs and CTs and turning into patient-specific anatomy models, not generic normal model, to speak. This technology really was rolled out because of patient engagement. In the United States, this is a very important thing for patient retention. It is also becoming very, very important for patient consenting process. And you can imagine that if you have a patient-specific model, you can really give them a deeper understanding of their own pathology. Here's an AVM, for example. You can tell them more about the inflow, about the outflow in 3D, and let them fly through their own skull, if you will, and show them their own anatomy. It really gives them a lot of clarity and clarifies a lot of confusion for most patients. And this is, of course, what grabs all the headlines, because patients would then go on the media and other places and say, this really helped me. This is very clinically applicable, and it made my experience with surgery much, much more acceptable. So a big headline grabber for patient engagement. then we began to know that this technology we can start to use in other ways. Now, I'm not going to talk about teaching and anatomical research per se. I'm going to talk about mainly about surgical planning and clinical applications. So first, we decided, oh, we can use this for actually planning the operation. Okay, so let's talk about a little bit about AVM. It turns out that the system that turns the 2D image into a 3D image can really pick out the onyx really well. So for high-grade AVM, where you're always confused about, okay, what is live AVM and what has been killed by the onyx, sometimes it gives you a very, very good image as to where the live AVM is remaining and where the onyx is. So here you can see that the turquoise, the bluish turquoise, is really the onyx, and the live AVM is green. And it's much easy to appreciate in this 3-dimension model that you can rotate and spin and dive in and zoom out and zoom in, rather than using 2-dimensional images where the onyx gives you a lot of artifact. So this is what I said, the beginning stages of using this technology for surgical planning, only looking but no touching. Well, obviously the next phase is touching, changing the models, so surgical rehearsal. And here we begin to talk about keyholes now. This is a patient with an optic nerve mass. And we are going to now not only change her anatomy to 3 dimensions, but alter the anatomy for surgical rehearsal. Let's plan a supraorbital keyhole and take a look at what the access point is. I'm going to prepare my McCarty burr hole, but only do the supraorbital keyhole for now without the orbital osteotomies. So we can drill the bone, we can erase the bones, take it, boom, it's gone. We can drill down the floor of the anterior fossa, and then we can measure with the system the angle of attack to the top of that orbital optic nerve tumor and say, okay, this is how much room I'm going to have, this is how much freedom I'm going to have. Next, we can say, okay, let's add to it. Let's add the osteotomy of the orbit, and let's see how much that adds, or whether it adds anything at all to the bottom, to the top, to the sides of the tumor. So again, osteotomy done, orbital roof taken off. And here you can see that the measurement to the central angle is much, much larger. And the orbit, I mean, the globe is there to show you that. So surgical rehearsal is beginning to be a thing for us, and using all these models to test it out and see what approach is best. Here is another example. Let me go back one slide. Here's an example of a pineal tumor that we use this for rehearsal. There are many ways of getting at this, so let's see whether one way is better than the other on the virtual reality. So let's do an interhemispheric approach. It probably is not applicable here, but let's see whether it is or not. We go down between the hemisphere along the falx, and we see that the corpus callosum is in our way. And we kind of knew that on the MRI scan, but here it shows in vivid 3D detail that the corpus callosum and the veins are in the way of the tumor. What about a supracerebellar infratentorial approach? We practice this. We hug the tent, dissect underneath the tentorium to the vein of Galen complex. We see the precentral vein of the cerebellum coming up, and then the yellow is the tumor. All right, that's the access. But look at my neck. My neck is really crooked, and the tentorial angle is perhaps a little bit steep for this approach. Let's prove to ourselves that the paramedian approach is better. So the paramedian infratentorial approach, same vein of Galen complex, there's your tumor. My neck is not crooked up, the angle is great. So after rehearsing this, we said, okay, even though we kind of knew that, I think the paramedian approach is in fact the best. And here's the paramedian keyhole. So paramedian keyhole, somewhat big, don't need to be 4 centimeters anymore. There's your basal vein of Rosenthal. There's the correlation between the VR and the actual surgical view. Endoscope is docked. We are now taking the tumor out underneath the left-sided basal vein of Rosenthal. Dissect, dissect, dissect. And it really gives you the confidence that this is going to work, because you've already done this once in virtual reality in the office, and you know that the angles are fine and the exposure is fine. There's the wall, the third ventricle, and so on and so forth. And it really gives you again, the confidence that this is going to work, because I've already done this. I know the pitfalls and whatnot, and what I can and cannot see. Now, with this paramedian approach, the only issue is going to be in the ipsilateral thalamic wall, the third ventricular wall on the ipsilateral side on the left side. So you'll see that after the big chunk comes out, we will need the 30-degree endoscope to see the ipsilateral wall. So 30-degree endoscope, there's a residual, dissect, 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 take it off the ipsilateral third ventricular wall, and you have got a clean field after that. So again, especially for young surgeons who haven't done 1,000 of these and first time using the endoscope perhaps and whatnot, the virtual reality rehearsal really gives you a lot more confidence that you're not going to hurt the patient and you're going to do the operation properly with a keyhole exposure. In this case, the paramedian infratentorial keyhole. So advanced applications. We're learning more and more ways of using this technology that we were granted, and we're just learning to use the applicability. Here's an interesting one. An occipital tumor that's benign, okay, intrinsic. So if you did a infratentorial, transtentorial approach to this thing, you might have trouble knowing where to cut the tent, because this thing is not going to appear very clearly distinct from brain. And if you cut the tent in the wrong place, you could be really lost, even with two-dimensional navigation. What about practicing this in the office? What about putting dots? If I go from dot number 1 to dot number 2 and cut the tent along those 2 dots, I know that I'm going to be right underneath the tumor, and I'm going to have no doubt where the tumor is. So let's practice that. Here is the patient-specific model with the tumor and the tentorium lined up. Here's dot number 1, dot number 2. We're going to cut along those dots from dot number 1 to dot number 2. And there is no question whatsoever that the tumor is going to be right above me. I'm not going to need to look for it and be fearful that I'm lost. So now this brings up the clear concept of, hey, what happens if you integrate or couple virtual and augmented reality with navigation? That's the obvious place where this concept is taking us right now. Let's stop 1 second before we talk about surgical rehearsal coupling with navigation to what I call the Goldilocks Principle. Remember, the main tenet of keyhole surgery is completing the surgical goal safely with the least amount of tissue damage. And then another way of looking at it is what I call the Goldilocks Principle. Remember the Goldilocks and 3 Bears. She went in and found the bowls of porridge and the beds and all that. And it was really about the porridge being not too hot, not too cold, just right. So we want the keyhole to be not too big, not too small, just right. And with that, Goldilocks Principle comes to 3 S's. It's really, how do you get the just right? It's really about the size, specificity, and safety. About putting the perfect size, not too big, not too small, just right. Perfect specificity of location, not too anterior, not too posterior, just right. And being able to do all this with the minimal tissue damage with safety. So the Goldilocks Principle is going to be shown here. There's no better way of talking about the Goldilocks Principle than perhaps juxtacondylar and transcondylar approach. Because here, you really want to take just the right amount of bone. If you take too much bone, you're going to hurt the craniocervical junction. There you go. And if you take too little bone, you may not have enough room to complete the job safely. So just the right amount of bone is critical. Okay, practice that. Practice that with the technology in the office with this patient-specific model. And when you find the Goldilocks opening where it's just right, take that as a template into the operating room, couple it with the navigation so that your operation becomes not navigating to get out of the woods, but navigating to copy something that you've already done. Here's the template. We're going to take that template into the operating room, and we're going to use navigation to reproduce that template with our drilling live. What about now the next obvious concept then, hang on 1 second. The next obvious concept then is turning that template into something that we can inject into the microscope or endoscope. Because for that, with the first example of the juxtacondylar, you're matching a template that's on one screen to the navigation screen that's on another screen to the patient's actual anatomy. If we can put all those things into the same field, into the same screen, then you've got a very good advantage. So now comes the concept of injecting the virtual reality template as an augmented reality object into the endoscope, in this case for a transtuberculum approach to a meningioma. All right, so we're going to practice this transtuberculum approach in the office. Oopsie, oh boy. We're going to practice the transtuberculum approach in the office, and septotomy, followed by an ethmoidectomy, followed by a sphenoidectomy, followed by the transtuberculum opening. And we want the perfect sized opening for this tumor. And then we're going to do that in the operating room and inject that template as an augmented reality object onto our field. And there you have a match. There you know that my bone opening is not too big, not too small, just right, in just the right place. We're going to open the dura and take the tumor out with confidence that this is going to be the right opening for the patient. Another example of the concept now, using a burr hole microvascular decompression example. Now, a microvascular decompression can be accomplished through a very small opening if the opening is in the exact right place. And that right place is, of course, the transverse sigmoid junction. On two-dimensional navigation, that is sometimes very difficult to confirm. So what if we do that placement of that burr hole in 3 dimensions inside the patient-specific model? We will have no doubt whatsoever where that transverse sigmoid junction is. And we're going to drill inside out. We're going to drill inside the skull outwards. And there's your burr hole drilled inside out. And we're going to use that as a template in the operating room as an augmented reality object. So here's the patient anesthetized and positioned. We're going to inject the AR image. You see the template burr hole with the dot. Okay, we've marked that on the patient's skin. That determines our skin incision. That determines where our burr hole is. And we're going to copy that burr hole from the template, AR template, to the patient. And there you see there's absolutely no hindrance of the movement of the instruments. And you can complete that in a 13-millimeter burr hole with entire confidence that you're right where you need to be at the transverse sigmoid junction. And you can therefore use a very small opening. How about safety? So remember the 3 S's being size, specificity, and safety. So now we understand that AR can actually project other things onto the field that makes it perhaps safer. Here's an anterior petrosectomy example. So here's a petrotentorial tumor. We want to do it through a Kawase approach with the anterior petrosectomy. And, you know, to be honest, I drilled into the cochlea once myself. So with that embarrassment, and that's something I learned, I now practice this in VR and I inject the objects in AR. Here's foraminal valley. I'm going to put a dot that for my own choosing at the lateral aspect of the Meckel's cave right there. That's going to be my anterior pole of my drilling. I have, there's your Kawase. I have put in patient-specific cochlea, labyrinth, and the wall that is the plane of the IAC. That would serve as my posterior margin of the drilling. And I'm going to first practice the drilling in the office and see how much of the drilling I need to do to get access to this tumor because of the specific size of the tumor. So drill, 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 drill. Start from medial going lateral. Once in a while, I'm going to bring back in my cochlea to make sure I'm not going to drill anywhere near it. There it is. I'm not anywhere near it. Now, do I have enough space to do the job? Let's bring back the tumor and let's see. Tumor is right there. Okay, this is enough. I have enough of an opening there to do my resection. I don't need to do any more. I don't need to endanger the 7th-8th nerve complex or the cochlea. Now, inside the operating room with the patient anesthetized, this is augmented reality objects that are navigation integrated. So the cochlea is exactly where the cochlea is. The wall of the IAC is in yellow. They are in patient-specific, navigation-specific placement. So I'm going to drill with those things in my field. I have X-ray vision. I cannot possibly drill in the cochlea in this situation because I can see that in light blue. And then I duplicate the opening, and there it is, the tumor, plenty of room to work. And I have not taken the cochlea or the IAC or any of those things. My final example of this is with the clinoidal meningioma. Again, this safety, specificity, and size of the opening. I want to do this clinoidal meningioma through a very small opening, and I want to no bigger than 3 by 3 as the classic mini pterional. So we're going to practice actually 2 different keyholes with this. And this is Almefti Group 2. It is perfectly placed and sized for a minimally invasive approach. Let's do 2 minimally invasive approach and see whether they are equally good or one is much better than the other. Here's a supraorbital keyhole. I'm going to do an osteotomy of the orbit. Boom, gone. Drill down the clinoid extradurally. There's the anterior clinoidectomy with the tumor out, put the tumor back in, take a look. I've got plenty of room to do this through a supraorbital keyhole. Let's try the mini pterional. We're going to drill inside out again. The burr hole is placed exactly where I need to be at the junction of the greater and lesser sphenoid wing. I drill inside out. I put a marker there to mark that burr hole. I would never be confused where that burr hole should be. I do a 3 by 3 opening, inferior and posterior to that, very small opening. Drill down the sphenoid wing, again, anterior clinoidectomy, and so on and so forth. And what I've discovered here is that those 2 keyholes are identical in safety for this removal and plenty of room. So because of that, and because the patient had a very light eyebrow, I decided to do the mini pterional. So that's the template I'm going to take into the operating room. That's the template that's going to guide my incision and to guide my opening. And this is, again, the concept of operate inside out. Remember, I drilled the burr hole from inside out. I'm also going to make the surgery inside out. I made the craniotomy, and I'm going to use that template to determine my skin incision. So I'm operating from inside outwards, which is a very weird thing for us to think about, because we obviously design surgeries the other way. So set up the augmented reality, integrate it with navigation, project onto the anesthetized patient the objects that we have, and the burr hole and the craniotomy. Make sure that the anatomy is well aligned. And then I'm going to draw that opening, that mini pterional opening, onto the patient's scalp with the patient positioned and anesthetized. And then that will determine where my skin incision is, which is behind the hairline, by the way. And all I'm doing here is I am duplicating the opening that I've already done in virtual reality in the office and projected as augmented reality onto the patient in the operating room. And then duplicating the clinoidectomy and so on and so forth. And long and short is that it's a 3 by 3 centimeter opening, quite small, and the clinoidectomy goes fine. You can see that we're drilling towards the optic canal. By the way, the optic nerve, when you project it in as augmented reality, really guides you towards the optic foramen for the clinoidectomy here. There's a peeling of the Hakuba. See, Mike, I can do Hakuba too. And there's your optic nerve, and there's no doubt that's a foramen right there. So you're going to drill on top of it, unroof the optic nerve, and the rest of the extradural clinoidectomy, as previously described by so many other people who are much more expert at this than I am. So here's unroofing the optic canal, and then the whole clinoid comes off after you drill the optic strut, which is lateral and inferior to the optic nerve. Drilling the optic strut, completing that, and then the IAC is right there, exposing the clinoid segment, and the clinoid is in one piece, and out it comes. So I'm not going to show you the rest of the video here. It is really just taking out the meningioma. It's not very exciting, and it's low anterior opening. There's the tumor. There's the optic nerve getting pushed towards the medial side, attacking the base of the tumor, and so on and so forth. So not to belabor the point. So I'm going to end there, a little plug for the book. A lot of these concepts that I've talked about are in the book, which is incidentally on sale at this moment. But I would love to take any questions regarding this. I hope that this is at least a little bit interesting for your audience. And I think that this technology really helps. In this day and age, I don't think anybody's really doing thousands and thousands of these to get to those kind of levels, and especially with the young surgeons who are very skilled, obviously, but getting more and more experience, there is no harm. There's certainly a lot of benefit of doing the surgical rehearsal and having these navigation integrated templates to help with your confidence and with the safety of the operation. Now, the skilled surgeons are going to say what they said about navigation many decades ago, is like, I don't need this. I've done this my way so many years. Why do I need this? This is child's play. I've done 1,000 of these Kawases and anterior clientectomies. Why do I need this? Well, you know, those surgeons are now using navigation as well. Those naysayers are using the technology. Sometimes we don't really need level 1 data to tell us that something is better. This is certainly going to make things safer. It may make things more efficient and quicker. So my question is, if you can afford it, why not use it for the patient's sake? Perhaps not for your ego's sake. So with that idea, I'm going to stop sharing my screen and take any questions that comes up.
Yeah.
Walter,
Yes.
can I ask you something?
Yes. Lucky, go ahead.
Thank you, Atul. So, Walter, very interesting paper, and as you rightly said, it's not for the. I think it's a great tool for educational, instructional stage for people who start with, and I'm sure you get your trainees, residents trained with this. Just wanted to ask you a thing about the brain shift. I understand that, like navigation and VR, you would definitely get advantages from the approach and reaching there, the bony landmarks and dural landmarks or sinuses for that matter. Does the shift really alter your plan?
Absolutely. As a skull-based surgeon, I have the luxury of my tumors not moving. So that's a very good point. If you, for example, if you put DTI and you say you have tractography and you have the motor fibers coming in, and you say, okay, I'm going to project the motor fibers as an augmented reality navigation integrated for glioma resection. Well, once you take out 5 centimeters of the glioma, those fibers are no longer where the augmented reality is going to show you. So the augmented reality is only as good as your navigation is. If the brain shift happens with navigation, it's going to happen with the augmented reality. This is not usable, not very useful for major brain shifts for intrinsic tumors. Again, as a skull-based surgeon, I had the luxury of the tumors not moving, and I know that it's going to be there, right above the clinoid, and the clinoid's off, boom, there it is. So brain shift is not, a very a major thing for my tumors, and I'm very lucky with that.
Walter, are you using this technology on a regular basis or only in selected cases? Or...
Well, another great question. I think that, again, if I have a large intrinsic tumor, I'm not going to use it. I would say that I'm using technology almost 75% of my cases. You can almost find an applicability for most cases. And then again, the intrinsic tumor is not so much.
And how many, are there any other group in US who are using this technology?
No, absolutely. Absolutely. This is now becoming more and more prevalent. They are all over Europe now. They are becoming, well, they have a couple of units in Asia, but in the US, it is getting more and more prevalent.
This is which company is making?
And here I have to say that I am an occasion consultant for surgical theater, and that is Surgical Theater. They're a company based out of Cleveland as well as in Israel. The one thing that I want to say is to add is that you will see that a lot of the anatomy and the bony anatomy is not as detailed and not as professional and polished as some of the other VR systems that you see. I would be quick to point out that the images that you see on my VR and the AR with surgical theater is really patient specific. They're turning patient data into those models. They're not generic models. For generic models and normal models, you can really spiff up the bone and make it perfectly almost like normal bone, and then your details are that much more clear. But these are patient specific models, and they take about 10 to 15 minutes to generate. So. Professor Goyo, you're muted. Atul, you're muted.
Yeah. This is a great instructional presentation from you, Walter.
Thank you.
And I'm sure this technology is not going to take too many years to spread all over the world, and for several cases that we do on a regular basis. And I really am sure that your presentation will help several young and several senior people, and this technology will indeed prosper. Thank you very much.
One last thing, if you will allow me to add that this is a plug. There's a neurosurgical focus issue on AR and VR coming out. So if
Yes.
anybody's doing work on this, please submit. And then there is going to be a session at the Bogota meeting for the World Fed on AR and VR. So if you're all going to Bogota next year, please come and join us. Thank you very much.
Thank you. Thank you. Thank you, Walter. Lucky, will you introduce Mike Ivan, please?
Yeah, sure. Welcome, Mike. For the people who don't know Mike, he's assistant professor in neurosurgery and he's chief of the cranial and neuro-oncology at the Miami Community Hospital. Is Jackson South Community Hospital, University of Miami. And we'd like to listen to him. He's going to speak to us about the approaches to challenging schwannomas. So,
You know what,
Mike,
Lucky,
Yeah.
Mike works with very well-known people like Jack Marcus and Roberto Hiros. Roberto Hiros is, of course, one of the legends of neurosurgery and one of the very respected neurosurgeons all over the world. And there is no question that he has influenced so many people. And I'm sure Mike, direct descendant of that heritage, will give us some fantastic presentation. Mike, please.
Thanks so much. Thank you, Dr. Goel, and everybody else for inviting me today. It's really a privilege and an honor to talk to you. And this is kind of a mixed up talk just about some of my thoughts about schwannomas and vestibular schwannomas. We have a large program here at the University of Miami with 3 skull-based surgeons, including Dr. Morcos, who I think you all know, as well as 5 neuro-otologists. So yeah, very, very busy, over 150 to 200 schwannomas a year that we manage. And this was kind of some of my takes on those cases throughout my time here. Just quick disclosures. So I'm going to try to cover these ideas, background of vestibular schwannomas, retrosigmoid approaches and what's beyond that, the learning curve that I've had, perfect surgery and how sometimes they don't go correct, and my viewpoints on endoscopic surgery, management of bilateral schwannomas, dealing with schwannomas during COVID and some of the future. So it's a lot to go through, so I'm going to kind of try to go quickly, and please let me know if I go over. I don't think we need to go into the background of schwannomas with this audience. We're all very, very familiar with both why they come and what symptoms they cause. But I thought it was interesting, the Mayo Clinic just published a paper showing that the prevalence of vestibular schwannomas is actually 1 in 2,000 adults, indicating that there's many patients that probably have vestibular schwannomas that are undiagnosed or slow growing. Obviously, we know the treatment paradigm is quite simple: observation, radiosurgery, microsurgery, but I would argue that it's one of the most debated topics in all of neurosurgery is the decision of when to do what and how to treat the quality of life for these patients and the tumor at the same time. And it's a tough balance, as you can see here. We know that stereotactic radiosurgery does a good job for controlling these tumors, but we also know that it doesn't cure the concern for hearing loss. And in fact, 10 years after treatment, only 25% of patients actually preserve hearing. And there's some new studies coming out, especially with Dr. Kanzioka, talking about kind of this neoadjuvant radiosurgery, this idea of treating small tumors when the hearing is perfect, with the hope that you could kind of prolong this curve and have better outcomes long term. And that data is pending soon. Also, microsurgical resection, we don't have to go through the risks of this. Obviously, the biggest risks are to the facial nerve and hearing loss. And we know that that's really correlated to tumor size. It's been around for 30 years saying that larger tumors tend to do worse with hearing preservation surgery. And I would say that these numbers are quite generous. I would argue for tumors greater than 3 centimeters, the hearing preservation rates are more like 10 or 15%, not 25%, as indicated here. But we know it's also not just the size, right? If you have a large fundal impaction, large inner ear invasion, IEC is eroded, then those patients tend to do much worse, even if it's a smaller tumor. But if you have a larger tumor where the IEC is not involved, you have a much higher chance of preservation hearing. But the idea of preserving hearing I think is what's most frustrating as a surgeon, is because there's so many reasons why somebody would lose hearing, not just from surgery, whether it's compression of the nerve, compression of the artery causing vascular injury, degeneration of the organ of Corti, endolymphatic hydrops, or even most recently, Diwali in 2015 showed that TNF alpha secretion from the tumor causes cochlear damage. And that's really the toughest one to predict, because you have patients where they have small or medium-sized tumors, good hearing, that you're watching it conservatively, and then all of a sudden they start losing hearing without any suggestive of tumor growth or whatnot. And how do you know when that happens, or predicting that? And we're doing some research on that right now to try to know that, so you could kind of predict better when to intervene. So the traditional approaches, as we all know, for these surgeries are retrosigmoid, middle fossa, translab, also obviously depending on tumor anatomy and the preservation of hearing. And Dr. Spesser gave this great talk to us a couple months ago in Miami, talking about his approaches to complex CP angle meningiomas, and how he's kind of over the years tailored his approaches to be more simple, rather than trying to be more complex with combined petrosal approaches or adding additional extension to the retrosigmoid or extreme far laterals. And this is just one of his slides showing that he's kind of tailored towards doing more retrosigmoids. And I would say that that's kind of the same approach that we have here in Miami, that I think maybe 20, 30 years ago, we had more of an equal retrosigmoid translab middle fossa, if I look at the data from Dr. Morcos and Dr. Hiros. But more recently, we've trended towards this idea that retrosigmoids are really the workhorse for these tumors. It's a quicker approach, and therefore the patient surgery are less. It gives you more access to superior and inferior trajectories. And obviously you have hearing preservation. And even in the small tumors where we were used to be doing middle fossa, we found that the retrosigmoids we could do equally, if not faster, and with better outcomes. But those are not the only approaches. I mean, here was a patient that I operated on early on, a young guy who actually presented with non-Hodgkin's lymphoma, had a large acoustic neuroma with loss of hearing. And the question for me was, this had a really large inferior extent all the way down to the foramen magnum. Was a retrosigmoid the Brecht approach? And I think if I did this today, I probably would do a large retrosigmoid. But early on in my career, I was extra cautious, and we ended up doing a far lateral. We actually watched this patient for about 6 months as he went through treatment for non-Hodgkin's lymphoma, actually, and then it did not grow. We then took him to the operating room, did a far lateral, and even though the approach kind of took an extra maybe 20 minutes to open, the surgery, we definitely cut off about 2 hours of surgery time, just because the view was a huge wide opening coming from below. You could obviously see how the lower cranial nerves, which are going to be a major issue with this tumor, were involved, and it gave us a large working window. And now I've watched him over the last couple of years. This is 4 years ago. He got married and had a kid, and he's doing great. Another interesting case, sometimes they're not always vestibular phenomena. This is a 51-year-old who presented with facial weakness. So already very strange for a vestibular phenomena to present with facial weakness. And she actually presented with a kind of a Bell's palsy picture in 2012. CT didn't show anything. She came back in 2014 after her facial kind of paralysis improved, but then worsened. And again, unfortunately, this was called as normal. But you could see there's erosion of the petrous bone here, just behind the geniculate ganglion on the left, indicating this is likely a facial nerve schwannoma. Now, the interesting is, what do you do if we were to catch that at this time period? This was not managed correctly with just some tramadol. What are the kind of the protocol for facial nerve schwannomas of this size with a facial nerve function of 3 out of 6? You know that with grafting, you're not going to, resection and grafting, you're not going to get better than the 3 out of 6. Do you expand the corridor by drilling and decompressing the nerve? Do you radiate? Do you observe? And I think it all depends on what you know about the patient. In this case, we saw that it was growing, and so I think intervention would be needed. There's already decompression here of the facial canal, and so decompression would not be needed. We would have radiated at this time point, but she was lost to follow-up. Came back 4 years later with obviously much worse symptoms, complete erosion of the petrous bone here on the left, and expansion of the tumor pretty significantly, complete facial paralysis and hearing loss at this time point. And here's kind of what her tumor looked like. So I think if it presented at this point, it'd be hard to know exactly what kind of schwannoma this was, if it would be a trigeminal nerve or facial nerve schwannoma, or even a malignant nerve sheath schwannoma. But I think regardless of that, the approach is to remove this as much as you can. And so in our case, we decided to do a middle fossa translab transcochlear approach with it, also a kind of a neck dissection because it involved the jugular bulb and jugular foramen to remove the tumor. We discussed the options of facial reanimation in this case at the time of surgery, but because there was some question of malignancy, we wanted to wait for the pathology. The patient was also not really interested in that at the time. And interestingly, this tumor ended up being a cellular schwannoma, which is a very interesting subtype, which sometimes can be confused by a malignant peripheral nerve sheath tumor because there is necrosis, as you could see on that preoperative scan. However, the Ki-67 is low, SOX10 is elevated, and these patients actually end up doing very well, as you can see by this Kaplan-Meier curve up top, much different than a malignant nerve sheath tumor, much more like your benign tumors. And so just watching this is appropriate, no radiation. And this is her 2 years later, still showing complete resection, no recurrence, and she's back to work. Not interested in facial reanimation at this time, although it was offered to her. So obviously I'm the youngest one on the panel today, and I'm sensitive to being a junior skull base surgeon. And I think it's important for junior surgeons as well as residents to always look at what the reported outcomes on the experts are, but also try to seek out what was their learning curve and what did they do early on, because it's important to understand that when you start your training, that you're not going to be like Dr. Goel and having thousands of cases under your belt. And so these are some interesting cases, reports on the learning curve for vestibular schwannomas, saying that when they kind of went through their learning curve and kind of reached that peak between the 40th and the 100th case, improvement in outcomes at the 56th case. And here's actually a review of cases, number of cases to achieve competency in these tumors, and anywhere between 25 to 100 cases before you really start to have improvement in your outcomes. Sammy's number of 1,000 vestibular schwannomas is one of the gold standards of kind of complication rates, and here are his numbers. I'm not going to go through them, you can read it on your own, but 81% of cases having good facial nerve function afterwards. So I was lucky enough to train with great mentors at UCSF, and also now have even better mentors with equally as good mentors here at Miami. And so I always compare myself to them as well as the literature. But in reality, when you start practice, you're balancing a lot of different things. Here I am doing vestibular schwannoma with my fellow and my chief resident, fine line of letting them work, but also kind of prove your own learning curve and push it along the way. And your learning curve oftentimes looks more like this than you would like to kind of look like here. So when I looked at my own cases, I've done 75 acoustics so far. Again, workhorse is majority of them retrosigmoid approaches with some translabs. And if I look at the outcomes, the complication rates are very similar to kind of what's published, which is reassuring. But I do notice my own learning curve here. If I look at the first 25 to the last 25, much better performance with achieving a near total or gross total resection with more than 95%. Facial nerve outcomes, these are facial nerve outcomes at 6 to 12 months, not immediate post-op outcomes, but much significantly improvement with my facial nerve outcomes. I used to be very liberal with using CSF, lumbar drains, and EVDs to get decompression of the posterior fossa. And I've become more confident with not doing that. And I think this is key because keeping the cranial nerves dry throughout the case is not necessarily a good idea. And when you have that lumbar drain in, it's open, and the EVD is open, those nerves are just being kind of exposed to the microscope for the hours of surgery, and they do dry out. And I think that's a big reason of why the facial nerve outcomes are improved. Also, 20% decrease in OR time is key as well. So some learning points that I've put together: avoiding bipolar use for vestibular schwannomas, I think, is key. And when I initially read this, I thought that was very difficult. Obviously, there's some tumors that are very vascular, but it can be achieved in cases that are able to be done like that. Medial lateral and lateral to medial dissection. Trying to avoid pulling on cranial nerve 7 as much as you can. Working medial lateral, and then only when you get to the cisternal component going lateral to media. Operating on a slack brain. I try to use sharp dissection as much as possible, and avoid CSF leaks. Recognize that these schwannomas are much different than meningiomas, and they respect the nerves and the vascular structure is much better than a meningioma. And make sure you use your mentors. So this is a classic case of where I tried to use all those points, and it did well. This is a rare case of a glossopharyngeal schwannoma, and you could see it's a small tumor, and so the expectation here is to have a great outcome. But obviously, they're challenging cases because they're involving the lower cranial nerves. And so my approach here is really sharp dissection the complete time with almost zero use of bipolar throughout this dissection. It's a small tumor, and so it's not like an impressive, difficult case, but yet it is challenging because the risk here of dysphagia is critical. And so here we are opening the capsule, CUSA to debulk it as much as you possibly can. Very gentle retraction here on the 7th, 8th nerve complex. Again, only sharp dissection as much as you possibly can. Here we're getting down the vertebral artery, and here we're finally getting to the 9th and 10th nerve. And again, very, very gentle, sharp dissection only, trying to remove this tumor as carefully as you can. And very just tiny bipolar at the end to remove the last piece. And then when at the end you have great anatomy here of all the cranial nerves from 5 to 11, the vertebral artery 6 in the distance there. And this patient did well postoperatively with no dysphagia dysarthria. So, but when these small tumors, even in the perfect case, there's a lot of decision points to make. So this is another case, a 40-year-old with a small vestibular schwannoma, hearing loss and imbalance, nystagmus preoperatively, had good ABRs beforehand. Small tumor, 2 centimeters. Here in Miami, we're pretty aggressive with surgery because of the young age. Here we operate. And so we did a retrosigmoid approach. Gross total resection was done. We were able to keep the superior vestibular nerve and preserve hearing. But now the patient woke up with severe dizziness and required 6 months of vestibular therapy, yoga, and everything. And eventually he went back to running marathons with good hearing. But even with that perfect surgery, he was really disabled for the 6 months due to this dizziness because of this superior vestibular nerve that we left. And so, and here's another case, very similar, almost the same exact story, a little bit worse dizziness, good hearing preoperatively, another small 2 centimeter tumor on the other side, good T2 plane on the T2 preservation, ABR is present preoperatively. We were able to keep the vestibular nerve. Hearing wasn't preserved in this case. We weren't able to. But again, same issue postoperatively, severe vestibular therapy issues because the superior vestibular nerve was kept. He underwent intratympanic gentamicin ×2, and eventually we had to take him back for vestibular nerve sectioning about 9 months postoperatively. And as soon as we did that, he did dramatically better. He literally walked out of the hospital with all of his balance and issues kind of improved. Even though his hearing was gone completely, he was much, much happier with that. So this question of when to take the superior vestibular nerve in these cases is a challenging one. And again, is not just a straightforward answer. There's a great paper here done by Unal, which talks about nerve anastomoses between the superior vestibular nerves, inferior vestibular nerves, and facial nerves and cochlear nerve. And it happens in about 10 to 15% of patients where there's cross transmission of the nerve fiber conduction. And by not taking, sometimes by preserving the cochlear and superior vestibular nerves, it ends up causing issues with their balance because there's still this kind of frequency issue of stimulation that the body doesn't know how to overcome. Now, we don't know how to predict this kind of cross transmission of nerves preoperatively, And so I think the word is still out as to what that is. Obviously, we practice preserving the nerves as much as possible, but I think in cases where hearing preservation is not indicated, taking the superior vestibular nerve would be the right move in order to prevent this postoperative disability. So Walter gave some great slides about endoscopic and keyhole approaches. And for retrosigmoid openings, my openings are typically only about 2 centimeters in general. And so I think the keyhole approach in this case is very limited. But I do agree that bringing in the endoscope really occurs. And here's a great example of when that happens. This is a epidermoid tumor that I just did a couple of weeks ago, a CP angle. Patient had some tinnitus and facial nerve spasms before surgery. And at the end of the case here, this month, here we get in the first axis. So here we're working through this epidermoid was very difficult because it went between the basilar artery and the brainstem, and so here we're working through the basilar perforators, which is definitely tough. Finding the 6th nerve, but at the end of the case, right here, we're working the IAC to tease out the epidermoid from the IAC without kind of drilling. You see labyrinthine artery and ICA here. And so with the microscope at the end of the case, we removed everything, but we brought in the endoscope and you could see down into the IAC, much more epidermoid kind of going into the IAC, and we're able to then use the endoscope to then tease out this last little piece. And I think this can be used for meningiomas, epidermoids, and I've used this for a couple different cases. And I think this is the great use of the endoscope in this retrosigmoid approach to try to remove and reach this last lateral extent without taking the half hour to sometimes hour and a half to drill out the IAC, depending on how far you need to drill. And this will save you a significant amount of time during surgery. Another great area to use this in was, this is a chordoma case, the petrous apex. And we approached this via Kawase, but you could see here in the preoperative films that the chordoma goes extremely inferior to the IAC. And you would argue, can you reach that far inferior? And in this case, we actually did. This is me and my chief and fellow. We operated for a large amount of the case using the endoscope with the drill to drill down the petrous apex anterior to the IAC all the way down to the jugular foramen through a Kawase approach. And another great way to use the endoscope. In this case, we're all extradural, and I think it's much easier to use the endoscope kind of to get around that corner and reach down inferior. And you can see here in the post-op scan the lower extent of the drilling that we were able to achieve, which is about a centimeter and a half inferior to the IAC to remove that tumor. So the last part here is I just want to focus on NF2. We have a large, we're growing NF2 center with research, and these patients are very difficult. And I think the balance of quality of life and tumor control is much more weighted towards preservation of all their symptoms. And so the scale is much different, even though the treatment options are essentially the same for unilateral and bilateral schwannomas. All of these patients basically develop bilateral vestibular schwannomas by the age of 30. And the treatment paradigm, though, is much different, with surgery really the last resort in these cases. Observation is key. We have some chemotherapy like Avastin that could be used. Radiation also for early growing tumors and young patients with hearing, and then surgery only at the last resort when hearing is lost, because hearing preservation and facial nerve preservation is key in these patients. But here's an interesting case. So there's a patient who presented, I have the slides next. 64-year-old who presented with hearing loss back in 1996. On the left side, she had vestibular schwannoma, had it resected subtotally and then treated with radiosurgery, and obviously had hearing loss. They missed it on the subsequent scan, but she had an early vestibular schwannoma starting on the other side. That was watched, and over the years started to grow. They treated it with CyberKnife here in 2015 in necrosis, so they were hopeful that it was being treated, but it wasn't. Continued to grow, and we saw her. I first met her in 2018 when she was starting to lose hearing. So what's the plan here? Do you just go in and remove this right away, even though it's obviously growing, patient's obviously declining? In this case, we decided not to. We decided to wait because she still had usable hearing on the right side, and we knew hearing preservation would be extremely unlikely. So we recommended Avastin. Unfortunately, financially, it's extremely expensive here, and so she was not able to get it. While we were trying to get authorization for it, her hearing began to decline and eventually disappeared. So now what are your options? And here's where we did our brainstem implant for this patient, auditory brainstem implant. And this has been around since 1979. It's not a new technology. It was approved here in the US in 2000, and really a new device was approved in 2015. There's a few centers that do it quite frequently, but none in Florida. So we were the first ones back 2 years ago to do this. And what this does is this is a machine interface that basically will receive auditory stimulus and then bypass the cochlea, the cochlear nerve, and then stimulate the cochlear nucleus here in the brainstem directly. And you'll get some kind of sound out of that. This is what the device looks like. Here's the small array with 21 electrodes. The external part of the device looks like this behind the ear, and you have a magnet. There's no incision here. Everything is completely closed, and this is just a magnet that transmits the signal with Bluetooth. Here's the size of the implant in my hand, and the placement of it is in the kind of the dorsal-cochlear nucleus, which is just above the ninth nerve at the foramen Luschka, into this lateral recess of the brainstem. Indications for use right now in the US are patients greater than the age of 12, and they have to have a diagnosis of NF2 with either unilateral hearing loss that you'll take with surgery to be bilateral, or they already have bilateral hearing loss and have failed other treatments. Obviously requires a multidisciplinary team, and luckily we have a great one. In these surgeries, it's critical to monitor all of your lower cranial nerves. And most vestibular schwannoma surgery, I do that anyway. But in this case, it's critical because when you place the electrode, you want to know exactly where you're stimulating. The surgical incision for these is a little bit larger because you have to plan for the implantment of the actual device posterior to your incision. So it looks like this. These are typically all translab approaches because you're not hearing sparing, you're taking the hearing. So here's our otologist doing the translab. Here's me removing the tumor. Here's what the implant kind of looks at. Here's the sigmoid transverse sinus here in our translab. And here, as we're tethering down the implant behind that to the bone. And then here's the placement of the actual paddle into the brainstem. As you place it into the lateral recess, like this, your audiologists are actually going to be able to stimulate in the operating room in real time to understand if you have it in the right place. And what they do is they basically check every combination of the electrode to see if you could stimulate an electrically evoked AVR or an EAVR at a certain wavelength and amplitude. And if you can, then that's good for that combination. You want to have as many combinations possible because that will translate into the better response and better usability for this implant. And while you're doing the audiology itself, they could tell you if your paddle is too medial, too lateral, too superior, and inferior based on stimulation. And in this case, in our first patient, we had significant hypertension and tachycardia as we were too inferior over the 9th and 10th nerve. And so we had to raise that. And it's important to let your anesthesiologist know that could happen during the stimulation itself. Closure is difficult in these cases because many of them have multiple intracranial tumors, and it's hard to get a watertight closure, especially with the wire coming out of the opening. And so taking time to close this is key. And in our first 2 patients, we've done 4 in the last year. They developed pseudomeningoseals that required shunts. The second 2, we perfected this a little bit better, and we've got away without that. Here's what a post-op scan looks like with the implant in place. And then after implantation, 6 weeks later, the patient comes back to the ICU for about 2 days of programming where they're able to program tone, amplitude, and different sounds with our audiology team. And again, it needs to be in the ICU because of this risk of tachycardia and severe hypertension. So here's a team, and the experience can be quite emotional for the patient. Here's the patient here as we're turning it on.
Dime si está subiendo. Se oye claro. ¿Se oye claro? Sí, se oye claro. ¿Qué oyes? Los sonidos. ¡Tú oyes los sonidos! Okay.
So this is the first time that she's heard anything in 5 months. And so, you know, for a patient who's completely deaf to all of a sudden start hearing again, even though it's minimal sounds at first until it's programmed, it's really, really emotional for her to hear something. And immediately she could lip read tremendously better full sentences. And the data shows that as well. I'm going to skip this case in lieu of time. but just with our second case of placement. Here's a CT scan showing kind of the exact placement of the electrodes and how the wire and placement actually looks in and of itself into the lateral recess. So what should you expect out of these patients? They can detect medium to loud environmental sounds, and conversational speech is what most patients do. 90% of them also are able to determine rhythm and volume, as well as some improvement in speech recognition, especially with lip reading. And they can have recognition of environmental sounds, like the difference between a bird and a siren, or a car alarm and somebody else. And so that could be critical and helpful. And then a small percentage, about 20% of patients, will improve speech recognition without lip reading. So if their eyes were closed, they could actually hear and understand a conversation in those outcomes. And here's kind of the outcomes showing how much improvement you could have, especially on the right here, with sentences with both lip reading and the ABI together. You have about a 30 to 40% improvement in their ability to understand continuous speech. Also, data showing that with the number of electrodes that are stimulating, you have a better outcome score with speech recognition. In our first two patients, we had 16 and 18 electrodes that were working, which is why I think they did extremely well. In the last couple of minutes, two things I want to talk about one was COVID and schwannomas. COVID is a prevalent pandemic, especially here in the US and in Miami. This was our first patient that we operated with during COVID for schwannoma. The patient was kind of developing some brainstem compression with hydrocephalus, and we decided to take them. We have an extra drape here. It's hard to see, but we have a separate drape on the outside of the microscope here. And so that while we did was a translator approach, all the bone dust was kind of being removed by a vacuum system in the drape that we concocted kind of during surgery. And I just wanted to kind of let everybody know that that was one option if they did need to do these surgeries during COVID, or if a patient was COVID positive. And now, most of these cases, because they're benign tumors, we could wait until they're negative with their testing, but and occasionally a patient comes in with worsening symptoms that can't wait, and this is our solution to those situations. So what is the future for vestibular schwannoma and NF2 tumors? I think it's, if we focus on the tumor part, we started looking at sodium fluorescein for better ways to visualize the interface between tumors and the facial nerve. And we're starting a clinical trial with that. Walter already touched on this ability to do AR and VR in surgery. And here in Miami, we're developing our own kind of virtual reality system, which looks like this. Multiple people in the room are actually able to visualize it and can see in real time while you're prepping and looking through a patient's head how to plan for different approaches and how to prep and drape. I think that's going to be key for education. Modeling, the treatment of these and medical therapies is also key, and we've developed our own kind of vestibular model system here where we could actually implant into rats our human brain tissues to monitor their tumor growth, as well as monitor hearing and vestibular schwannoma loss. And using this model, we've been able to test some very new elements of targeted therapies. And so I think in NF2 specifically, precision medicine is going to be key. And talking about radiation, chemotherapy, gene therapy, surgery, I'm not going to go into the details in this talk, but we have been making progress. All the pathways, or many of the pathways in these NF2 tumors, are known. The most interesting trial, which we just started last week, is this brigatinib, which is an EGFR and MEK inhibitor, and we're actively recruiting as well as many centers in the world. And we hope that that's going to work well, but obviously I think it's going to be a combination therapy ultimately that's going to work for these tumors and not just a one single therapy. So I'd like to thank, obviously this is work of a great amount of people at my university, and I'm just a small part of it. So thanks to all of the people that I work with, Dr. Din, Talishi, and Morkos especially. I also want to do a quick plug to our Brain Tumor Symposium that happens on Wednesdays, tomorrow. It's 5 p.m. Eastern Standard Time. We have Dr. Muldoon from Brazil speaking tomorrow about brain mets. The following week, Dr. Aghi from UCSF will be talking about Cushing, and then Dr. Stoop will be talking the following week. So be sure to tune into that, and you can either follow me on social media or go to our website here if you have more questions about that.
Thank you, Mike, for that wonderful presentation. And The only thing is this implant thing is, as you know, is in business for several years, but still not has taken the real upstream.
Yeah.
Why is that? Why, these implants have been existing for more than 20 years now, but still, and they are being used everywhere, but still not a in thing in this. What do you think? Why is this?
Yeah, I mean, I think it's financially still that the cost is extremely high, and it's really limited to only people with bilateral hearing loss, which obviously is a very small percentage of patients. I think as we start to learn more with this technology, the ability to kind of restore people with unilateral hearing loss to a point of where it's actually beneficial to them more than just using a cross hearing auditory supplement or some of the other supplements that we have. That's where I think the major impact will be. I think the other part is, some of the computer software to do this transmission, not to wear such a big device externally, is all being developed. I mean, I don't know if you saw Elon Musk's Neuralink talk last week, but it was incredibly impressive for what he's done in a short time with this brain-machine interface. And I think as the technology develops to become cheaper and cheaper, and it's going to become within the next 10 years for sure, I think we're going to be having a discussion about when to implant the Silver frenoma patients at the time of resection for these implants. But you're right, it has taken a long time, and it's I think now though we've reached a threshold with the technology that will be taking off.
Michael, can I ask you something technical about the ABI? You put the electrode in the LUSCA. How do you fix it?
Yeah, so that's a great question. So there are two flanges on the outside of it, and those flanges you could kind of cut or modify so that it does kind of rest in the right place. And once it's in there into the lateral recess in the right place, and you have just a little bit of tension from one of the flanges, it really doesn't move that much. So in one instance, we did use like a 9/0 suture to kind of tack it down to the dura. But in the other three instances, it actually just worked well with just a little bit of Surgicel to kind of wedge it into that one spot, and it didn't move at all, and we didn't need to tie it down.
Yeah,
but those are the
unlike the DBS electrodes, it's kind of a floating in a open space. I was just wondering, it must be very significant. The flanges must be holding it really tight and in place.
Yeah, I mean, there's not a lot of movement in the skull base of the brain. So by tethering it to the dura, the wire to the dura, and then kind of having it in that location, we haven't seen any movement or migration. And the longevity of these is actually much better than a cochlear implant. So longevity of hearing preservation or the hearing restoration that they achieve, I didn't show it, but there's one paper that shows up to 20 years that they don't really degrade on the amount of restoration that they have. There is quite a bit of variability in what restoration everybody does get initially, but once they get that, it lasts for a long time, indicating that this doesn't migrate once it's in there.
Thank you.
Thank you very much.
Sure.
Now, before Dr. Vernon introduces Luis Borba for his presentation, let me introduce Luis. Luis is one of the most popular skull-based neurosurgeons of the world, I will say. People like to listen to him. You will see how enthusiastically he will present. You will see for yourself. And his work has been appreciated all over the world. More importantly, we have, me and Luis have grown up together in the field of skull-based surgery and the field of neurosurgery. And he was with Al-Mefti when I first met him. And he has grown to a wonderful, now he's the president of the Skull-Based Society. He's organizing the International Skull-Based Society meeting in Brazil. And I wish many of us can go and join him. Vernon, please introduce Luis.
Hello.
Yeah, wait. Okay, your internet seems to be okay. Luis, please go ahead, share your screen, and let's begin.
First of all, I want to apologize that I was confused with the time, you know. Sorry, I missed the Dr. Jean presentation, but I listened Michael Even is very nice presentation. Professor Go, thank you. I'm great honor to be with you. You are my mentor. You are a little bit older than me, maybe 10 years older than me. I look older than you, but you are older than me. You are the real man in the skull base. Now you are not changing the history of the skull base. You change the history of one pathology that everybody in the world was treating one way. Now you are showing the world the different way to do this. Let me start some organize here. I will talk today about one way to reach the skull base. Today, in the era of minimally invasive, the no-knife surgery, gamma knife, X knife, any knife, no knife, they say that you don't need more skull base. To learn skull base, we need to go to the lab. This is my first temporal bone dissection, December 24, 1993. In this time, I couldn't find sigmoid sinus. I couldn't find the labyrinth. I just find the bottom of the box that I crossed the temporal bone. But I didn't give up. I believe in my mentorship with Professor Al-Mufti that the temporal bone is part of the cranium and you should learn. You don't need in every case. In the great majority of the cases, skull-based tumor in the area, you don't need to do transpetrosal approaches. But you need to know. If you want to treat lesions in the jugular foramen, we need to know temporal bone. If you want to treat lesions in the craniocervical junction, we need to know the bottom of the temporal bone. If you want to treat lesions in the temporal area, we need to know the top of the temporal bone. If you want to treat lesions that you can approach easily by press sigmoid approach, we need to know temporal bone. If you have a very nice ENT that they are working together, it's a good, you can do a team, it's good for the patient, it's good for your health. You can go just in the main part of the procedures. But we as a neurosurgeon, you should know temporal bone because the way that the ENT see the temporal bone is completely different the way that we see. We see the temporal bone as a route, as a highway to the skull base. In the greater majority of the time, you use the temporal bone to reach something, not to treat pathologies inside the temporal bone. But there are some pathologies that you are treating inside. Today, I'm very worried to see some master surgeons around the world say, why to treat this tumor? Petroclivomeningioma. This patient has had just diplopia and headache and hydrocephalus. Why don't treat all the hydrocephalus? Do you know why? If you don't remove this tumor, this patient will die. Not now, but soon. And it's our job to treat the patient from the best way and the best treatment that he needs. For this, we need to understand the anatomy of the skull base. We need to tailor the approach to each tumor. We need to understand that the retrosigmoid approach gives you a wonderful view than the 90% of the tumor you can take, the tumor from retrosig. But you also need to know that there is some situation to understand more the anatomy. And the petroclival area is the most difficult area that you should understand. If the tumor is coming to the clivus area, if the tumor is coming from the anterior petrosal area, if the tumor is coming from the tentorium, are completely different. 1 millimeter can change completely your way to treat these tumors. But what cannot happen is this. You go to the most important, I don't say important, the largest meeting in the world. Neurosurgeons from many, many countries. And you go to the booth of Gamma Knife Lexel. That is very nice tool. The radiosurgery, the Gamma Knife, the Linac are very, very nice and useful tool. But you cannot sell this as a treatment for radiosurgery. How you see this beautiful young lady? She asked for his father one iPad, and she got this iPad. Maybe this some people is selling in the world. It's not what she needs, not what she wants. This is make her worry. Because you have a surgery like this, very small attachment in the tentorium. When you cut the tumor and separate for the tentorium, it's gone. Now the tumor will be completely free, retrosig, supracerebellar. You can go there and remove this small ball, like a baseball ball. Huh? You can take it. No radiation, no other kind of treatment. The patient is cured. The most important than any kind of approach that you can teach, you should understand what treatment the patient needs. Sometimes the patient don't need treatment. In this situation, do you see? It's very simple situation that the tumor is coming like a ball. But if you go to the WNS, you see a very nice and large booth with beautiful picture. This patient today could be his head irradiated. The pre and post-op removal. When you go to China, you see Professor Zhang showing 1,546 petroclival area meningioma. Around 50% he used the transpetrosal approach. It means that the transpetrosal approach, anterior petrosal, posterior petrosal, total petrosal, is still alive. And we need to know. It's not to use to everybody. It's like I have one hammer used to everyone. It's not like this. We just need to know. You can reach the petroclival area by anterior petrosal, by posterior petrosal, by retrosig. And now is coming a new tool, in a new approach, the endonasal, the transclavus surgery. But the most interesting when you talk about this approach that today is popularized, many people don't know why. The video from the endoscope is wonderful. The picture is amazing. You see the structure with very high magnification, looks like perfect. But you see in this paper from our friend, our former resident, Daniel Prevedel, and his team, the distance between the 6 nerves, that is the limitation of the approach, 8.8 millimeters. It means you can treat tumors like grapes. A small tumor, maybe you can go. But the great majority of the tumor in the petroclivar area are oligosymptomatic, few symptoms. Sometimes very huge and just headache. The great majority of the tumor are like this. And in our countries, sometimes like this is a whole box of wine. How we can do this for the nose? You can go there, do a woodpecker surgery. Woodpecker surgery, bite a little bit and go home. No complication, everybody happy, no incision, but no treatment. This is not the way to do medicine. It's not the way to do neurosurgery. This is not the way to be a doctor. You study, you train to do the best for the patient. This is our goal. This is our mission. We could reach the area by anterior petrosal, remove just this small area here. You call petros apex. Or you can come press sigmoid or retrosigmoid or petrosal. When you do the anterior petrosal approach, you're removing this area as Professor Kawase described long time ago. The trick of the surgery is total understand the indication, and not to everyone. The anterior petrosal approach is limited by the posterior cavernous sinus. The fifth nerve has to be in the middle of the approach. You can liberate totally the 5. Totally liberate the 5 is the key of the anterior petrosal approach to petroclivar area. If you open the porus trigeminalis and liberate the 5, you can mobilize the 5. And the tumor that go intradurally, the inferior limit, will be the internal auditory meatus. If the tumor go down, you need to use another approach, or retrosig, or the pre-sigmoid approach. We need to understand very well this anatomy. And the way to learn this anatomy is you go to the lab. You spend some time in the lab. I spent almost 3 years in the lab, Dr. Omefti. When I arrived there, there was no cadaver to do the dissection. We start in a very small room to get one head. The drill that I was using, I bought in the Walmart. Do you know the store? The Walmart. The Dremel. The same you use at home to fix something. But I had a goal that I want to learn to do this. And the anatomy makes you more comfortable to do and essential to the skull-based surgery. To understand in the skull-based surgery that before open, before plan the approach, you should learn How are you close this big hole in the base of the skull? I need to prepare flaps. I need to prepare pericranial flap, then temporal flap, fascia lata, and sometimes this fancy substitute. That is good, but sometimes our patient cannot afford. It's important to plan to close the cavity. Let's start one case for you. That the tumor removed the petrous apex for you. This is a chordoma in the petrous apex area. Could be a chondrosarcoma, it's more lateral, but the pathology was chordoma. The tumor is make the approach for you. And the cavernous sinus invasion is not cavernous sinus, it's displaced anteriorly. You go, dissect the tumor, the soft tissue, but the most difficult part to remove in the chordoma is not the soft way. The most difficult is this one, to drill the bone that is affected. And sometimes you have islands of tumor away from the main mass. And this, the neuronavigation will help you, but sometimes the CT scan is not showing. See? You have to clean maximum that you can, because this always in chordoma, we give a post-operative radiation. For proton beam is maybe, I think is the best way to treat the pre and the post. Same situation like this, chordoma again, but totally inside the bone. You do just an anatomical removal. You do the peeling of the middle fossa. The third, V3, V2, superior orbital fissure, remove the petrous apex, expose the ICA, and remove the bone that was totally invaded. You do a bone removal, like an orthopy, no? You become an orthopy. Okay? Remove the bone. This, the neuronavigation help you. The intraoperative CT will help you. The anatomy is crucial. And the pre and post-op removal. There is lesion also in the petrous apex that you should treat. It's called cholesterol granuloma. There are 3 ways to treat cholesterol granuloma. One, from the nose. Okay, go to the petrous apex, open, and drill, and communicate with the nose. The problem, the mucosa come down and close the cavity. The other way is coming from infralabyrinthine. Drain and keep a small drain there, a small tube, okay? Maybe close. And the other ways is from the middle fossa. You go there, open the petrous apex, remove all the structure, and use vascularized flap to close it and completely obstruct the cavity. This is the 2 ways that they are using. I'm using this middle fossa that I think is definitive treatment for cholesterol granuloma. Don't do intradural approach for cholesterol granuloma. You have a meningitis, aseptic meningitis. If you do an intradural approach, try to go extradural, and the post-op use a lot of corticosteroids to avoid this complication. And pre and post-op, the cavity remains like this. Looks like you feel. Nobody in the world has more experience in trigeminal schwannoma than Professor Atul Goel. I ask permission to show him 2 cases. I know that you do different, but our goal is the same, to remove the tumor. I like the temporal bone. I study the temporal bone. I drill the temporal bone. I love the temporal bone. I go through the temporal bone. And this here, the anatomy of the fifth nerve is this. If you just follow the fifth nerve, if you just follow the anatomy of the fifth nerve, you go from extradural to intradural. But you stay outside the arachnoid, and you leave the arachnoids to the nerves, to the 7, the 8, to the vessels. You do one extra arachnoid approach. It's good. See, you just follow the anatomy here. Now you're becoming more brave, more courage, and you start doing this one. 99% of the neurosurgeons say you should go retrosig. And it's right. I think the best approach for this is retrosigmoid approach. Go to the angle, transverse, and sigmoid sinus, and remove the tumor directly there, and follow the nerve to the porus trigeminalis and Meckel's cave. It's correct. But I decided to come from the middle fossa, you know. And what I saw, I did the peeling of the middle fossa. I removed the small part was in the Meckel's cave inside the gastric ganglion. I decided to come in this area and expose and widen this porus trigeminalis, removing the petrous apex, identify the root of the trigeminal, the superior petrosal sinus, totally liberate the trigeminal nerve, and now you are following the nerve from extradural to intradural and communicate the 5 from the middle fossa to the posterior fossa, cutting the tentorium and totally liberate the 5. Then you start to do the dissection, you peeling the arachnoids. See, the 6 came there, see? The basilar, and leave the arachnoids and the branches to the vessels and the nerves. This way you are going around the tumor. First, a very long decompression, and go around like an onion. You know onion? You go peeling the onion. See? Now the tumor will come from the posterior fossa. I didn't see the brainstem. Now I can see the brainstem. Remain a small piece of the tumor still in the Meckel's cave. The 6 is there. The basilar artery is there. There is some arachnoids over the basilar artery. And you do this. The 4th nerve with his arachnoid. You save the nerves. The best way to protect the nerve is keep the arachnoid with them. And you follow the 5th nerve from the posterior fossa to the middle fossa. Just follow the nerve. The tumor was coming from here, see? And after you use a vascularized flap to close completely the cavity and the post-op, see? Immediate post-op. There is a slight 6 here, but he came back. He recovered very, very well. You see? And the post-op, pre and post-op, pre and post-op, a good removal of the mass. There is more than way than peel a cat, no? You know that's possible. If you see this tumor today in the world, the people say, man, it's a cavernosinus meningioma. You cannot touch. Gamma knife, radio surgery, finish. No biopsy, go there and just burn. But if you look this, the tumor is coming from here. And follow the fifth nerve in the Meckel's cave. And from there, going to the posterior part of the cavernous sinus. This tumor is extra cavernous sinus, is in the Meckel's cave. If you do the correct approach, if you find the fifth nerve, if you remove the anterior the petrous apex, or maybe you remove the petrous apex from the middle fossa or from the posterior fossa, you decide the way you want to remove the petrous apex. You know, I prefer to remove by middle fossa because I can remove much more bone. I have more exposure. From the retrosig is more limited the removal of the petrous apex. But the people say that they remove how much they need. It's correct. But the idea here is that this tumor you can follow from outside to inside. Don't need to do radio surgery for this situation. There's another situation like this. This also could be retrosig, but there is this area here. This area we call is the tentorium. If you want to remove radically a meningioma, you should remove the tumor and the attachment. In the great majority of the time, in the skull base, it's not possible to remove all the attachment. But you should try. You should try to remove maximum dura around. And the idea that you have in this situation is coming also from the middle fossa. Liberate the 5, you see the hole in the window that open to you, just removing this small piece of bone. The basilar, the 5, and you can do work in this direction here. And the tumor will be here, attached to the tentorium. You can cut the tentorial back, you cut the tentorial anterior, and sometimes follow the tumor to the middle fossa, using this route here, not this route here. You can do by retrosig. Okay, you can do it. But you also can do by middle fossa. The way you do frontotemporal approach, more temporal. Why frontal? Because now I'm going here in the base of the frontal lobe and remove CSF CSF, not leak, CSF. I'll not remove a little bit, a lot. I'm not using lumbar drain, no more lumbar drain. Because when you do this removal of CSF, the temporal lobe relax. You can do this. Now we're doing the peeling. Peeling, is not cutting. See, peeling. See, like the ladies does. Now some men are doing also. See, here's the great superficial petrosal nerve. Here's V3. Here's our petrous apex. Where is the carotid artery? We should know it's there. V3, petrous apex, great superficial petrosal nerve. You start to drilling the petrous apex. The cancellous bone, you go inside, from inside to outside. Okay? Come to the base of the middle fossa, open the dura in the base of the middle fossa, expose the tentorium, expose the dura in the posterior fossa, open the dura in the posterior fossa, take more CSF, see, to relax the temporal lobe. This way you work in parallel to the base of the skull. Now have posterior fossa, the 5 in the posterior fossa, the tumor in the tentorium. You see the 5 there? This video is published in the operative neurosurgery in 3D. You can see in 3D. You can see very, very well. See, here's the tentorium. You go posterior, you cut the tentorium as posterior as you can, find normal tentorium, and now you mobilize this small tumor anteriorly. Before the last cut, look for the fourth nerve. See, is there. Now remove this small tumor. And you can follow the tumor. Here's the 5. See, totally liberate the 5. And you see, you can remove not only the tumor, but also the dura that is involved. Because if you leave this small piece of invaded dura in the posterior part of the cavernous sinus, in the Meckel's cave, the tumor will come back in that area. Because it's very important to do this. So the 3rd, the 4th will be here, the 5 will be here, the posterior part of the cavernous sinus here. When to stop the anterior part, we start to bleed. Start to bleed, you stop. Means that you are inside the cavernous sinus. You see this 5, 4, 3rd, and the 5 like this. In 3D, you can see very well the tumor, then the nerve is going up. You see, remove more again, start to bleed, you stop. You have this, 3, 4, and that. But the most important is this. Look the temporal lobe. It's good. Looks like you didn't touch. See? In the post-op, the patient will have, this patient had a slight facial pose, very slight, but recovered very well. Now that the lady, 1 month after surgery, Brazilian Japanese. I have another situation like this, you do the same approach. But this situation, the 5th nerve was displaced inferiorly. You remove the tumor that was in this area, expose the whole area, and the post-op preserve this. Just following the anatomy, just follow the way to reach. But the workhorse is the retrosigmoid approach. In the retrosigmoid approach, you can remove more you can imagine. Because many times the tumor, you give you the approach for you just follow the tumor. How you follow the mafia, You have the mafia, you're gonna catch the mafia, you follow the money. In skull-base, sometimes do the same thing. Gonna catch the tumor, just follow it. See, he'll give you the whole work. A large tumor like this, not petroclival, you can follow by retrosig, or tumor like this. My wife is talking here in a second. It's the problem to speak at home, no? Okay, a case like this, oh my God, it's petroclival. We need transcondylar, transpetrosal, trans something. Do you know what's here? The tumors come down. You see the here? Totally displaced. Retrosig. A simple retrosig. In this case, I expose a little bit more the sigmoid sinus, but to rotate. But the most important thing, you see this. Look, where was the attachment of the tumor? Just superior to the jugular foramen. You should plan your approach to the attachment of the meningioma, not to the bulge, to the attachment. Where the tumor is coming? It's coming from here. If it's coming from here, I don't need to remove the temporal bone. Pre and post-op, good removal. There is some situation that you can use retrosig, you can use petrosal, you decide. I do petrosal a lot, I do retrosig a lot. I feel more comfortable. I feel more comfortable. Does not mean that is the best way. See, I feel more comfortable to do case like this, petrosal approach. Do you know why? I go to the tentorium, I coagulate totally the tentorium, I cut the tentorium, and the meningioma became as epidermoid, white and bloodless. Is the trick that I use, cut total devascularization. If I go to retrosig, maybe bleed a little bit more. You can coagulate the tentorial from below. It maybe use sitting position. For me, it's more difficult. But I prefer to do bipetroso to cut totally the vascularization and to cut totally the tentorial where the blood supply is coming. Another situation like this, the people say, oh, remove this posterior part and leave this cavernous sinus here. Look, this again, the same situation that the former patient. Look, the 5 in the middle. Here, it's not cavernous sinus, it's in the Meckel's cave. But there is one thing here that is very important. See, this tumor is going down here. If the tumor is going below the jugular foramen, the lower cranial nerve, you cannot reach by press-sigmoid approach. You should use retro-sigmoid approach. If the tumor goes superior here, you cannot reach by simple posterior petrosal approach. You should use subtemporal approach. Because this, in this situation, I did press-sigmoid approach. I use retro-sigmoid approach. I use subtemporal approach. And I follow the 5th nerve from the posterior fossa to the middle fossa. And the tumor that was in the petrous apex, in the Meckel's cave, I could remove. And I left all the arachnoids to the vessels and nerves. When you see well, the vessels, the nerves dissect beautifully. Sometimes you make damage. If you leave the arachnoid to them, is the safest way to preserve function in the nerves. And the pre-op have this, post-op have this, press-op have this, post-op have this, and preservation of mobility. But there are some situations that is this. This you need petrosal approach. There is no way to come. See the attachment? See? You can come by retrosig, maybe. I don't know. Maybe the tumor will come down, you give you the approach. Maybe. I think this situation, we should agree. The press-sigmoid approach, the petrosal approach is the best way to do this. You come from here, you see all the nerves, have direct route, short instrument. The approach is larger, okay? You'll have more time you use more time doing the approach, but it's okay. But you have press-sigmoid, you have retro-sigmoid, you have subtemporal, you have many routes, many highways that I call to reach the area. But to have situation that you believe that you should do this approach, the posterior petrosal approach, but the anatomy will not help you. You see, this patient had just one sigmoid sign in the same side of the tumor. No, I drill more than 300 temporal bone for every approaches, pathologies, many diseases. But I'm always afraid to drill over the sigmoid sinus. This is small wall of sigmoid sinus. It's not easy to save, because this is very important to see the preoperative angiogram and see if there is good communication. Okay? Because as better you are, if you are great surgeon, a lot of experience, you know temporal bone, you can damage the sigmoid sinus, of course. It's surgery. Every case is different. In this situation, I decide to come by anterior. See, have to study this venous anatomy. I decide to come anterior. I remove the anterior part and left one part in retrosig that you come in the second way to do. From here, and from here, not from the middle. Another situation like this, a large tumor petroclival, you remove the tumor, you expose the area. See, you cut the tumor in the middle sometimes, see? How you have the whole anatomy here. You see the outer structure, same view. Very short instrument, 5th nerve mobilized, 7 and 8 are below. You work between 7 and 8 or superior to 5 or inferior to 5. You work in this direction here. And the post-op 6th nerve. The patient had a slight 6th nerve, and the post-op was worse. In very instance, in this case, wake up the 6th nerve. And in the middle, when he's in the middle, looks like recovered. The great majority of the time, recovered. But in this situation, after 3 days, make worse and never recover the 6th nerve. But I ask you, is a very high price to save this lady, to save her life, a 6th nerve palsy that you can do ophthalmological surgery and fix or maybe improve a lot? Is it a very high price? I don't know. I don't believe. Or situation like this, that you do the surgery that you believe that you cannot take it, there is PIA invasion. In this situation, I always leave one small piece of this. But sometimes happen in surgery that you don't know. I thought I couldn't remove. There was a small piece here fixing the brain stem. I went to one side, I went to another side. After I came back to the same point, the plane appeared by themselves. And the tumor gone. And the patient wake up with 4th nerve. Also, again, is a high price to treat a tumor like this. A 4th nerve palsy that you can fix with glasses. I don't know. But there are situations that in my hand does not work. Patient like this, man, diplopia, a tentorial meningioma more than petroclival. It's not petroclival, it's a tentorium with petrous incision, but also tumor here down. The patient has no deficit of the lower cranial nerves. In this situation, I prefer to leave a small piece of tumor in the jugular foramen and follow. Because when I try to remove the tumor that was inside the jugular foramen with no plane, many times there is an arachnoid plane. Sometimes there is no plane between the nerves and the tumor. I prefer to leave a small piece of tumor there, see, and follow. Maybe send to radial surgery if it starts to grow. Not in every case you can remove everything. You need judgment. Sometimes you need to leave for better of the patient. See situation, another case, same situation, I left a small piece there of the tumor. The way to do skull-based surgery, to do petrosal approach is this. You go to the lab, you do the surgery, you go to the war, and you have fun. See, this case you did in Siberia in 2014, the patient is very, very well. I hope Professor Gold can go with us next year. Maybe this year will be difficult. Next year, see Professor Gold there. You'll have fun, you'll have fun. Nice facilities, wonderful facilities. You have a very good equipment, everything you need, and you have fun. Very short words about paraganglioma. 5 minutes, no more than that. Anatomy is everything. Follow the anatomy, you follow the tumor. Dissect the anatomy and see the tumor. dissect the neck, expose the neck, the tumor will be inside the vein. Understand the anatomy of the temporal bone. See that sometimes you need to expose, sometimes you don't need to expose. The Hugo Fish, that is the man that developed the infratemporal approach for glomerular tumor, was the master, the man that demystified this surgery. He did the most beautiful job in this area, but he was treating every patient the same way. Everyone doing anterior sternum transposition. And the patient wake up with facial nerve palsy because of the approach. Today, you cannot do that. The approach cannot be worse than the tumor. Today, we are changing our philosophy about embolization also. We are not embolize everybody. We embolize when the tumor is large, when the patient has in the pre-op lower cranial nerve deficit. See, if the patient tumor is small, the patient has no lower cranial nerve deficit, we prefer to do the surgery without embolization. Embolization is not treatment, embolization is adjuvant. Also, radiation therapy, you can kill the tumor in the beginning, but the chief cell is still alive. The difference of radial surgery for AVN and the radial surgery for glomus, that glomus is tumor. There is a tumor cell. For glomus, you kill the vascularization of radial surgery. But the chief cell, the real cell, is still alive. And this tumor is a matter of time to come back. Maybe 2 years, maybe 3 years, maybe 4 years. I just saw a patient radiate almost 8 years ago. Now the tumor is coming in the same place, crazy, total irradiated area. If you don't know to do it, it's better to go to the lab. I'm worried about glomus now, because the people say, no, don't need to do surgery, don't know to do surgery. But the small tumor, they are central radiation, the easiest one. If you don't learn with a small one, how you do this big one that I show you now? You send this to radiation? Large tumor in the neck, large tumor in the jugular foramen. You should remove the tumor in the neck. You should remove the tumor in the jugular foramen. You should spray and post-op. If you don't go to the lab, you don't learn how to do this big tumor, how you do? If you don't learn with a small tumor, how you do these big tumors? And preserve the anatomy and preserve the structures. The people are very worried about lower cranial nerves. Some people still today say, oh, if you do glomerular tumor, everybody will have tracheostomy, everybody will have gastrostomy. It's not true. If you understand the tumor, if the patient has no deficit in the pre-op of the lower cranial nerves, it means that the anterior wall of the vein is preserved. It means that if you follow the anatomy of the tumor and preserve this anterior wall, you save the nerve, you save the swallow. You can do this in anatomy, you can do this in surgery. You just follow this anatomy. Facial nerve management. You have to tailor to each situation. Not every patient needs transposition. Some patients need, some patient doesn't need. Needs to plan and know and understand the way. This patient has a lower cranial nerve deficit, has no facial palsy. And the vascularization is coming only from external carotid artery. If the vascularization is not coming from the internal carotid artery, you don't need to expose the facial nerve. You don't need to play around the facial nerve. You can do the surgery just infralabyrinthine, leaving the facial nerve alone. Work just below here. See? And the patient wake up with this smile. No facial nerve because of the approach. The people say, oh, if you do anterior transposition with good techniques, everybody recovered. Okay, I beat you. If you show me a case that you did anterior transposition and look for this guy for 1 minute in his face, he will have some spasms. He will be different. Never will be the same. The best way to save the facial nerve is leave the facial nerve in anatomical position. Just expose that if you need. If you have a case like this, that the patient has facial nerve palsy, has hearing loss, has deficit of the lower cranial nerves, this is the easiest case. Do you know why? We have just one goal in this surgery. Follow the ICA. Follow the ICA from the neck. Close the external thoracic meatus. Work in the facial nerve. And do the removal. More you understand the tumor, more you know the way to treat the tumor. In a situation like this, the patient has facial palsy in the pre-op, has hearing deficit, is not totally deaf. That you need to understand that in this situation, you need to expose the facial nerve. You need to dissect the facial nerve. You need to expose the facial nerve. Here's the facial nerve in the parotid gland. This is the area. I show you drill the, I'm sorry, I go direct to the end because of the time. See? There is a tumor that in the posterior fossa that was followed there. See, there is facial nerve invasion. You find, you stimulate distal and proximal. There is no signal. You expose the facial. See the invasion here is red. It's tumor invading the nerve. You find the normal nerve here. You find the normal nerve here. You can use the graft that is in the field. That is great auricular nerve. Is in the field. It's just here. See? And do the graft of the facial nerve. For this, you need to know the anatomy. But this patient had in the pre-op facial palsy. Okay? You do this, you open the nerve, you harvest the nerve, the great auricular nerve. You put over the nerve. You remove this part here and put the nerve over it. Some glue up, and the pause up this. Herman's okay. 6 months, 1 year and a half. It's coming. Not to be the same, of course, but it's coming. Now you need to fix something. See? For the patient has total deficit, now is safe. Another situation like this, re-op, you can do the surgery also. You expose. And this patient has surgery before. You remove the big tumor, like with a petrosectomy. We identified the facial nerve in the parotid gland. This is the carotid artery. Was re-op, okay? Or the facial nerve in the parotid gland. We find the facial nerve in the posterior fossa. You do a stitch in the nerve in the posterior fossa. We fix this there. See? You have the graft from the posterior fossa to the parotid gland, fasciolata, fat, glue, lumbar drain, and pray a lot. Pause up. Almost 2 years, it's coming like this. Now can fix this here. But you save her life. To end, For me, neurosurgery is pleasure. If you do neurosurgery with passion, determination, see, I like meat, I love wine, I like football, Brazilian football, not the world, not soccer, not the American football, our football. See? You do, see, how long time you spend in surgery? Maybe 10, 12. If you're having fun, you'll help it. See you everybody in Rio, maybe March 22. Professor, we change the date, because now December will be difficult to have all the people there. In 22, we have the vaccine from Russia, from India, from America, from everywhere. And everybody could be there. Thank you. Sorry for a very, very long time, but I was having fun.
Thank you, Professor
Thank you,
Luis.
sir.
Thank you, Professor Luis. I had some internet connections. I'm back now. And for making it look so very simple, for this complex procedure making it look very simple. So one question is, what would be your strategy in a recurrent petroclival tumor? What would be your strategy of management?
Depend of the size, depend of the location, and depend if I did the surgery, you know. If somebody did the approach by different approach that I used to do, and I think that I can go by different approach and remove the piece, I go back. For example, if I do a petroclival meningeal by retrosig or posterior petrosal, if there is a small remaining tumor or start to grow again in the middle fossa, I can go by middle fossa and remove. If I left one small piece of the tumor that I couldn't remove, I follow it to see how will be the behavior of the tumor. If the tumor start to grow, maybe this is a good indication to radial surgery. See? Every case, I think, is different. Recurrence, second surgery, redo, is the most difficult surgery you can get. See? You lost the arachnoid plane, you lost all the thing, because this is like in love, you know. The first time, always the best time. You always should try maximum that you can for the first time. You'll never forget.
But you said no radiosurgery. You said surgery.
No, I don't say no radiosurgery. I say no radiosurgery in advance. I wait to see what's happening. Professor Goyle has, I think, Michael has, I think you have, case that you treat, you did surgery, and there is a small remaining tumor, and you wait 1 year, 2 years, 3 years, and nothing's happened without any treatment. If this small tumor that I couldn't remove start to grow again, that I see that the area I cannot reach safely, see, if I can come from different approach, see, if the tumor is coming here, was there, now it's coming in small part here. I think you could go there and remove, but it is not safe. You give to radiosurgery. Radiosurgery is very, very, very good tool. Very, very, very good. But for the real indication for radiosurgery, is small tumor, area that you cannot reach. What you are seeing today in the world is crazy. They are taking acoustic like this, vestibular schwannoma like this. Say, doing a woodpecker surgery, just bite a little bit, boom, and give you radiation. The people is giving radiation for large meningioma. The people is giving radiation for radiation-induced meningioma. I can show a paper. It's crazy. We cannot kill one of the best tools that we have in skull base. That is the radio surgery.
Thank you. Professor Goel, what would be your opinion for a recurrent petroclival? What would be your strategy?
You know, recurrent petroclival meningiomas are difficult,
Yes.
but possible. Difficult, but possible. As long as it is possible, we should make it possible. And when it is not possible, then we should think about radiation and other things. My philosophy is, as long as my knife can reach safely, and as long as my knife, there is a possibility of doing good resection, no radiation. Radiation will come when I will think that I cannot operate safely. That is my indication.
Thank you.
Anyway,
100%.
Louis, just let me give a fantastic words for you, my dear friend. Louis, you are wonderful. You are my friend for a long, long time. And you have made a wonderful presentation to our several people watching you. And I'm sure they must have learned the tricks and trades of skull-based surgery. As you mentioned, skull-based surgery is hard work. Skull-based surgery is passion. Skull-based surgery is love for the subject. Skull-based surgery is complete dedication. And complete means you cannot take it, okay, let me try. It has to be persistent. And you have shown it for several years. I have been watching you. We have grown. You are a little younger than me. You started first in 1993, temporal bone dissection. I started before you, much before you, my dear friend. But we have grown together, you know it. You were, you know, for a long time, I can see the same passion that you are talking now. 25 years ago, also same passion was there. So it has been a wonderful journey with you, my dear Louis, with you,
Thank
my
you.
friend.
And I'm following you.
Okay.
You know, if we don't do neurosurgery with passion and dedication, it's difficult to be a neurosurgeon.
That's right.
Because I think it's the only specialty that you can wake up in the morning, take a coffee, go happy to the OR, and come back very sad. It's the only specialty that it's every day. If you don't do it with passion, dedication, do your job, you'll never be a great neurosurgeon. See, like you. You are the man. You know, you are the man. Everybody's following you, Dr. Goel. Now you are changing the history of Chiari, you know. Now we are more famous than the real Chiari.
Brilliant evening this evening, and I would take the pleasure of introducing my friend Professor Atul Goel, with your permission, Vernon.
Yes, please go ahead.
So I don't think he requires any introduction, but I see a friend, a world-class neurosurgeon with a sixth sense, third eye, beautiful mind, golden heart, and indefatigable spirit and stamina. In addition to all this, he has been bestowed with a lot of hard work and big contribution by him, being more than 2 decades heading the unit in the State Medical College, KEM, famous KEM Medical College. Although he has a private practice in Lilabati, the famous private hospital, but he's done immense contribution to the field of almost every field of neurosurgery, including the skull base. And he is, as Dr. Louis, he is also very passionate about neurosurgery. And then today we'll have the pleasure of listening to him on his very favorite subject, skull base, approaches to skull base. Atul, please.
Thank you, Lucky. Thank you, dear friend. And thank you, Mike. Thank you, Louis, for joining us. And you know what, Louis, I have given more than 50 webinars in the last few months, 50, more than 50. And many of the people watching have seen the same things again, again and again. But still, I enjoyed doing surgery. I love to give my thought, whatever is in my heart and in my mind, I will like to talk. So as you know, skull-based surgery has been my passion and my life for a very long time. And I really started skull-based surgery in the era of MRI. When MRI was introduced in neurosurgery, skull-based surgery was born. And since that time, it has been my fortune that I started early with dissections, with multiple cavernous sinus dissections, with temporal bone dissections, and several hard work, persistence. There's no question about it. And there is no ego or pride in saying that. It is a fact. Nobody can do anything without very dedicated and continuous work. So what I plan to do today is to show you in my last 35 years of skull-based surgery, how I have changed my own style of surgery and my own exposures and my techniques. So this, as I have shown on several occasions, this is the book which I published in 1996. So 25 years ago, I published this book. And this book, if you have read this book, this is a complete monograph. All the techniques published in this book on the chapters which I have written on tumors are personal techniques. There is no review of literature. There is nothing like that. So if I am talking of Petrosal approach, what Petrosal approach I have contributed to that subject. So it is entirely a monographic presentation. And this book was very popular during those years. And this was reprinted thrice. And I had written with Professor Kobayashi, who was one of the very foremost vascular surgeons at that time. And if you see the cover page of this book, this is the cover page of the book, and you see my exposure, which I proposed during those times, of very heavy exposure. You see the mobilization of the carotid artery, mobilization of the facial nerve, mobilization of the Gasserian ganglion, drilling of the entire petrous bone, and several transcochlear, translabyrinthine, continuous working on the drilling and expanding your exposures, expanding your horizons. This was my life for several years on petrous drilling. And you have to really know petrous drilling. You have to really know how to dissect the facial nerve, how to mobilize the facial nerve. More important, as Louis said, it is not important to be able to mobilize facial nerve or the carotid artery or the Gasserian ganglion. It is important to know when to mobilize and when to move. Like he was talking about glomus jugular surgery is the most beautiful skull-based surgery. Whether to mobilize or transpose the facial nerve, that is the decision. And that is the, your learning process. Anyone can mobilize the facial nerve, but whether you need facial nerve mobilization, that is one. And whether you can avoid the need of facial nerve mobilization, those are the things which are important and that you have to learn with your experience. So what I am trying to show you is how my personal journey with skull-based surgery has been over the last 35 years and how I have changed by virtue of operating and operating and operating all the time, learning the quality and the nature of the tumor, the nature of how much you need exposure, how to dissect and how to go ahead with the surgery that you learn with tumor dissection and tumor operation. So first I will talk about olfactory groove meningiomas. These are very classical and very, these are also skull-based tumors, although they are relatively straightforward because of the location. And my journey with olfactory groove meningioma has been quite intense, and several kinds of olfactory groove meningiomas have come my way, and how to break the tumor, how to do the dissection, one learns and one progresses. This is a very beautiful teaching material for all neurosurgeons, how to break olfactory groove meningioma, because it is safe. Nothing is safe or easy in neurosurgery, but it is one good tumors to operate. So I recently published my series of 129 cases of olfactory groove meningiomas till the year 2016. So this is the largest series in the world on olfactory groove meningiomas. So in this, I had divided these tumors depending on the size, visual deficit, duration of deficit is very, very important, higher mental function, convulsion, and so many points I had given to these tumors. And then I had added the points and made, you see, radiological extension in the anterior cranial fossa, anterior third of anterior cranial fossa, middle third of anterior cranial fossa floor, posterior third. Paranasal sinus extension is a very negative factor, encasement of anterior cell. So many of these points I had shown in this paper, and then I had graded these meningiomas in grade 1, 2, and 3, and then I had suggested that the higher the grade, more difficult is the tumor. Essentially, what I want to show you is, early in my experience, in 1989 or 90, and during those times, my exposure was removal of the roof of the orbit on both sides. So my exposure was bifrontal, and exposure of the orbit on both sides, and leaving the middle part of the skull base, like you see here, the cribriform plate and the area. So orbital roof exposure was one of my very important components. Doing orbital osteotomy, bilateral orbital osteotomy, was one thing that was very commonly done during those years. We had also introduced a small technique. That time the drills were not so good like the osteotomes. So what we had shown is drill 2 holes here and use giggly sort to cut the orbital roof like that. So this was published in Journal of Neurosurgery. And also during those times when I was trying neurosurgery to learn various aspects of neurosurgery, I had also described transfrontal sinus. Just remove the anterior wall of the frontal sinus and go through the frontal sinus, although I don't do and I don't recommend, but this is one thing which I had described in several years, maybe 30 years ago. So this was my exposure coming and going down to the nose and doing bilateral orbital osteotomy. But as I progressed, I have, stopped doing orbital osteotomy on both sides. That is one thing. I have stopped completely. And second thing means I do subfrontal, not orbital osteotomy is not included in my exposure routinely. Sometimes, of course, it can come into picture, but routinely it is not done. And also, more often, I do unifrontal craniotomy. Like early in my experience, I was doing bifrontal craniotomy on a very regular basis, but even for large and massive olfactory groove meningiomas after 2014, bifrontal has never been done. So my exposures have reduced. On the basis of learning, more and more learning process with these meningiomas, which are difficult even when they are going on one side, quite a bit on the other side, you can actually come. It is not important to reduce the exposure. I am not advocating reduction of exposure, and I am not very fond of reducing the exposure, but many of these cases, most of these cases can be done quickly, can be done rapidly, and can be done with unifrontal basal frontal craniotomy. Many of these tumors extend on one side of the midline, and there is actually, you come from that side and start debulking the tumor, The most important thing in neurosurgery is learn how to demolish the tumor, break into the tumor, then coagulate widely on the base, and then debulk the tumor on the other side. It is possible. And this is what I do nowadays, that I don't do basal work too much, and I don't do orbital exposure, and I do unilateral subfrontal exposure. When I come from this side, many of my tumors are very huge and massive. So I may even remove some part of the frontal brain on the side on which I am coming quickly, dash on the tumor, debulk the tumor, debulk the tumor, debulk the tumor. Most important, most important and most critical, of course, every one of us knows that anterior cerebral artery and its branches and its perforators have to be preserved. And one small mistake can completely demolish the entire operation, that we have to know. More important is break into the tumor, learn the art of demolishing the tumor, and you can do a quick and rapid job with these tumors. Next, I come to tuberculum celli meningiomas. This was my article in 2001 where I talked about 70 cases. Now my experience is nearing 300, which is also the largest in the world. Tuberculum celli meningiomas are very fantastic tumors, and they are of various kinds, small size, big size, encasing the anterior cerebral artery, encasing the internal carotid artery. You see anterior cerebral artery encased. So they have their own kinds of problems. They can be calcified and ossified and encasing the anterior cerebral artery, encasing the internal carotid artery, completely calcified and solid, having lot of edema. So what we had done is we had graded the supracellular meningiomas according to clinical parameters and radiological parameters. And these are several parameters stating that, meaning thereby that all tuberculum celli meningiomas have different characters, and you can grade according to the various points and then analyze these tumors. And then according to the vision, more important, we had said, is the duration of vision, which deficit is, which is very important. And if you have hemispheric deficit, then it is a very negative indicator of difficulties of surgery. So early in my experience, when I was learning skull base and was doing skull base 2000, 30 years ago or 28 or 29 years ago, my exposure always involved orbital roof exposure and frontal sinus exposure, and unilateral subfrontal exposure was my exposure. So this was my cut, and this was my exposure for tuberculum celli meningioma. But now I do just unilateral subfrontal exposure. I don't want to show videos because it may otherwise become too big. So just I expose like this and learn the art of retracting the brain, enter into the tumor, start debulking and demolishing the tumor without, you see, as even Michael was saying, coagulation comes, but coagulation is not the primary instrument. Learn the art of demolishing and breaking the tumor, and that will take you, once you debulk the tumor, then you go on the base. And my coagulation comes very limited and very late in the operation. Once I have made space for myself to go to the base, I go to the base and then coagulate the base and then remove the tumor. So these tumors are very beautiful tumors. I don't want to be negative for a transnasal approach, but I don't believe transnasal surgery or endoscopic surgery for tuberculum celli has any role. I personally, this is my personal view. Though if you want to use, you can of course use it, but absolutely not. These operations are most beautiful operation, unilateral subfrontal operation, quick operation. Most important, even in this operation, is to expose and preserve the anterior cerebral artery. Very crucial. If you damage the person very heavily. So from a very simple tumor, you can make it a very dangerous and devastating tumor. Otherwise, you remove, the vision should improve. Almost always, you open the optic roof, optic canal, and if you have to remove the tumor from the canal under vision, this is my approach for tuberculum celli meningiomas. And as I have mentioned, I have got a wonderful big experience in my public hospital, in KM Hospital, where there is a factory of these kind of cases all kinds, calcified, encasing, not encasing. Pituitary stalk saving is the most beautiful and important thing. And always there will be a wonderful thick layer of arachnoid that separates the pituitary stalk. I don't think I have ever damaged the pituitary stalk in my entire surgical experience with tuberculum celli meningiomas. These are unilateral, subfrontal, no need to open the orbital content. And this is my change which has happened in my lifetime. And I have mentioned, it is a wonderful, and I don't recommend, even if you think that you can come from the nose and do it transnasal, and you say that I can save the anterior cervical artery, it is absolutely, in my view, it should not be done. Unilateral, subfrontal, or if you like terional, whatever, but transcranial route is the route for all kinds of tuberculum celli meningiomas. Then I will like to just say a few words about anterior clinoid meningiomas. In 2000, means 20 years ago, I introduced this classification on the basis of 60 patients. I have not recently written about my recent work on anterior clinoid meningiomas in the next 20 years, but it is quite a volume of cases. So anterior clinoid meningiomas are one of the more difficult neurosurgical problems because of the encasement of anterior internal carotid artery, the branches of internal carotid artery, and they can be from a absolutely good, fantastic result to a devastating result can happen. So this was the case I did in 1991, and several cases, they involved the cavernous sinus and they involve the internal carotid artery, whether to, how much to remove, whether to continue dissection around the internal carotid artery or not are the issues. Some small tumors which are calcified may be more difficult than huge tumors, which are more often soft. So my strategy is go with the intention of radical removal, go with the intention of complete removal, never go with an intention of whether it is in the cavernous sinus, whether it is in the carotid artery or wherever. But if there is some need, if there is some danger near some perforator, you try to stop. So this was my classification of anterior clinoid meningiomas when they displace the internal carotid, engage the internal carotid, squeeze the internal carotid, go on the other side. So there are various parameters about vision, about size, about relationship within. So I had made this classification and then grading. And then this was my initial surgical strategy: huge exposure, removal of the zygomatic arch for sure, orbital zygomatic osteotomy on several occasions, open the orbital wall, open this kind of area, and then do a very massive exposure. And this was the tumor long time ago I had done with some residue. This is also controversial whether to do something with that residue. Then I shifted anteriorly to a smaller exposure, but I still opened the orbital roof and frontotemporal, removed the anterior clinoid process, and opened the various structures for anterior clinoid meningioma in the initial part of surgery. But as I progress, I don't do this orbital work now. I don't remove the zygomatic arch or the orbital roof. I do a rather biggish, not so small, a biggish craniotomy like this. And then more important and most important is know where the tumor is, know how to demolish the tumor, and then go to the base, learn how to demolish the tumor, identify the attachment, then go to the base and remove this tumor. These are wonderful tumors to be removed and difficult tumors to be removed and dangerous tumors to be removed. But if you are able to remove, you give absolutely new life to these people. And we are here to encounter dangers and handle dangers and overcome dangers. So these are various kinds of anterior clinoid meningiomas which I have done during my career, and it has been a wonderful journey. And I will not say that it has been always a safe journey. I have created disasters, I have created hemiplegias, but those have been far and few, but they have been there. And I have learned that these tumors need to be demolished. Anterior internal carotid artery and its perforators have to be saved, and how you save and how you avoid unnecessary dissection, that you have to learn during your experience. Then I go to petroclival meningiomas, which has been even Dr. Borba's life and my own life, and I have done several tumors during my life, various kinds of petroclival meningiomas and various difficult tumors by extensive basal exposures, orbitozygomatic osteotomies and petrosectomy and all kinds of skull base exposures. So this was the skull base exposure I described in 1999 on the basis of 24 cases. When I had little bit changed my style. So this style came after a while. Initially, I was doing different kinds of exposure. So this exposure, if you see, I used to do quite often this exposure: removal of the root of zygoma, removal of roof of the condyle, removal of the roof of external ear canal, and partial mastoidectomy, and basal subtemporal craniotomy. So this was, mastoidectomy was included for the first time in the literature in the subtemporal exposure. So it was a basal exposure, right going to the petrous apex. So this exposure, I had shown that this is a good exposure. And this was my alternative incision I used to take like this. And temporalis muscle was always earlier rotated downwards over the zygomatic arch. So we said that if we rotate the temporalis muscle anteriorly, you can have a direct shot at the petrous apex. So this was the basal exposure and mastoidectomy right till the antrum, and then depending on the nature of extension, I continued my exposure down, and if necessary, I did facial nerve mobilization, carotid artery mobilization, but this was my initial exposure. Then in some of my cases, in the year 1995, actually, if you see this 1995, I described this technique from the middle fossa to cut the GSPN from the middle fossa. This is not from the total petrosectomy is not done. Here, just a partial mastoidectomy, no, partial petrosectomy has been done from the middle fossa, and GSPN has been cut, and labyrinthine and tympanic segment has been mobilized. And this paper is also quite widely referred in the field of skull-base surgery. So essentially what I'm trying to say is that my petrous bone exposures were very heavy and huge, but over the period of time, my petrosectomy has been reduced. I'm not saying completely stopped, but it has been reduced to a great extent. So in 1993, I mobilized the facial nerve for this tumor, and then I removed in 1993. But now if you ask me to do this same case, I may not do that kind of exposure. I will like to do conventional posterior fossa retrosigmoids. Now, for the first time, you see, retrosigmoid approach for petroclival meningiomas was popularized by Sami. But for the first time in the literature, we said that lateral supracerebellar approach is very good for petroclival meningiomas. So supracerebellar approach was good, and I described in 2004 28 cases. Now I see many people in the world using supracerebellar approach rather than retrosigmoid approach for petroclival meningioma. I think this was a very fantastic paper in 2004. And now I have done several cases with supracerebellar approach, even as Louis was saying about the cavernous sinus. It is how to remove, when to remove, how much to remove but basically the attitude has to remove. If your attitude is there to not to remove, then of course you can never remove. You should remove as much as you can safely remove, saving the sixth nerve, saving the ocular the nerves involved in ocular movements. It is very important to save these nerves. So this was another case which I did by retrosigmoid long time, about 20 years ago, and I have realized that retrosigmoid supracerebellar approach is a very fascinating approach. But of course, when you do retrosigmoid, the part in the cavernous sinus is little bit difficult, not impossible, but quite difficult. But removal of this part of the tumor is quite safe and straightforward. The only thing is, and I want to stress this thing, which is very important for these kind of cases, you need to operate in sitting position, which many people in the world are not using. Like in US, I don't think anybody is using sitting position. I'm not sure about Brazil, but sitting position is absolutely important for these cases. I must say that many stalwarts of neurosurgery like Yasser Gill, Sami, and Leonard Mallis have been propagating sitting position. And for me, I can reach this tumor in 5 minutes or 10 minutes by supracerebellar approach and then start debulking the tumor. I know how to demolish these tumors. I know how to go towards the base of these tumors, devascularize these tumors. Most important, as somebody had put a question also, the saving of the sixth nerve is very, very important in these nerves. I am not saying it is easy, or I am not saying it is always possible, but it is crucial. If you don't save the sixth nerve, you have damaged the eye to an extent that if you do not have the vision, that is better for the patient rather than having a sixth nerve deficit. So these tumors, initially, early in my life of neurosurgery, early in my life of skull-based surgery, were all middle fossa approaches, but many of these cases I now do with retrosigmoid exposure, retrosigmoid supracerebellar exposure, and these tumors, you see, these are, you can go right up to the lower part of the brainstem. You can expose the various things in wonderful exposure you can get. And my feeling is that you do it quickly, you do it safely, and you do it strongly. And many of these tumors can be removed in very, very quick time. As all skull-based surgeons mentioned, that time is the last thing for neurosurgeon has to think about. But on the other hand, if you just go on with these cases for hours and hours, more important is learn how to reduce the time. And many of these tumors can be done in a very quick fashion, in a time which is very quick. Like this tumor, now today I will like to do by retrosigmoid supracerebellar exposure. This tumor was not left behind because of any other reason, but the third nerve was difficult to was left behind. So let me show you this. I don't want to show you too many videos because many of you have already seen, but some who have not seen, you can get a wonderful anatomical demonstration by retrosigmoid supracerebellar approach for these tumors. And I have to tell you if I am right or wrong, but this tumor was done in less than 1 hour. Normal situation, many of the transpetrosal approach by itself involved 3 or 4 or 5 hours, but these tumors can be done in quick time. Now I go to trigeminal neurinoma, which is also my very important surgical experience. I described 73 cases in the year 2002. Till 2017, my experience was 260 cases. Now it is over 300 cases, which is also one of the largest in the world. This is my, trigeminal neurinomas we described that these tumors are interdural, located within the dural confines. Carotid is displaced, trigeminal nerve is displaced. So if you know that these tumors are within the confines of dura, work within the dura, and you can remove beautifully these tumors. Sometimes they are only in the posterior fossa, then you can use retrosigmoid approach. These are the dumbbell-shaped tumors, and my experience with these tumors has been very long. In 1992, I did 2-stage exposure. In 1992, about 30 years ago, nobody used one single-stage exposure. No, not nobody, but Mallis introduced in 1986 or 87 single-stage exposure through petrosal approach. Mallis also used subtemporal petrosal exposure for trigeminal neurinoma. But what we used to do in 1992, I did in 2 stages. First, I removed the middle fossa, and then I did posterior fossa. So 2-stage exposure in 1992, another case, 2-stage exposure was very much used even by me. But then, of course, we learned the dural anatomy of the trigeminal nerve and the dural anatomy of the posterior fossa component, dural anatomy of the middle fossa component, and then we changed our exposure. In 1995, I did this tumor by just widening of the Meckel's cave by infratemporal fossa approach, interdural. This, so more important was, as we learned the hard way surgery on trigeminal neurinoma, we realized that these tumors can be removed by very small exposure because they are not firm tumors, they are not vascular tumors. So just opening the Meckel's cave without, just opening the foramen ovale without doing any craniotomy. In 1995, I described this interdural approach. So that was the magic statement, interdural. I even removed the posterior fossa component, and this is the picture in 1993 or 94. In my paper in 95, I removed even the posterior fossa component of this tumor by just a very small craniotomy. And this was another picture in my book where I did from a very small exposure without craniotomy. But in general, for trigeminal neurinoma, larger trigeminal neurinoma, this was my exposure. And I described this basal lateral subtemporal exposure like I described for the petroclival meningioma. I showed that in 18 cases in the year 1999, I did trigeminal neurinoma with this exposure, and you can see the condyle, you can see partial mastectomy. But then as I matured, I just do smallish craniotomy, splitting of the temporalis muscle, doing a craniotomy here, exposure of the foramen ovale, and extradural or intradural for these tumors, I do intradural exposure. I used to do extradural, but intradural, then cut the dura along this and then remove the tumor, and then you can follow this direction. And these tumors are absolutely wonderful tumors to operate, and you give, more important is we described for the first time in the literature that these tumors arise in the region of the Gasserian ganglion. That is the first thing. Second thing is we described that these tumors are interdural in nature. Also, we said many of these posterior fossa component is also interdural in nature. And the third and most important thing we described in the paper which I published in 1992, this paper, sorry for this, that these tumors, that is very important. Preservation of trigeminal function was never described as a series. So we described 2002 that you can preserve the function of the trigeminal, the facial sensation, which is absolutely crucial. So this tri-compartmental tumor is also interdural. All the three compartments are interdural. So that is one very beautiful thing that we described. So extracranial extension, also we said that the dura is covering the extracranial extension. The tumor which goes in the V1, in the V2, in the V3 also have a dural covering or the perineural covering and work within the dura from a transcranial route. You can do a beautiful resection and you outside the tumor, and you can do a very beautiful resection by working within the dural confines. So initially my exposures were very huge and wide for these tumors, as you can see, but now my exposure, because I have seen so many tumors, I know the nature of these tumors, I know how to dissect these tumors, and this has been a wonderful journey. So this is another tumor. Many of you have seen these tumors, which I have shown on several occasions. This was the case of cavernous hemangioma, which is very, very vascular tumor involving the cavernous sinus. It is intracavernous in nature. And in 1991, I had done this tumor by orbitozygomatic osteotomy, and very huge exposure I had done, and I had published this in 1991. These tumors are within the dural confines of the cavernous sinus. They encase the internal carotid artery, go towards the intercavernous sinus. So more important is that they are interdural. So we described this 1996 paper was the first article in the literature which described extradural approach to intracavernous sinus tumors. Of course, Vinko Dolenz had described in 1983 or 84 extradural approach to aneurysms and various other tumors, various other vascular lesions. But for tumors, this was the first article in the literature. So cavernous hemangioma of cavernous sinus, no matter how big they became, they remain within the confines of the dura, and we describe this extradural approach to cavernous hemangiomas. This was the 13 cases I published in the year 2003. Now I have nearly 38 or 39 cases, and this is surgery is absolutely important. Go and expose the sixth nerve early in the operation, save the sixth nerve, then remove the tumor. These are heavily vascular tumor. You don't need to continuously coagulate. If you continuously coagulate, you will never be able to remove these tumors. And this is the only way you can get the restoration of the third nerve. You can bring the smile on the patient's face. Is gone, and this is a surgical. There's no radiation or anything will work here. Next, I go to foramen magnum tumors. Foramen magnum tumors are dangerous and difficult tumors because of the vertebral artery located here, odontoid process located here, joints and condyle located here, anteriorly the oropharynx and nasopharynx. So this was also a very big skull base problem, how to get to the foramen magnum tumors. And transoral surgery was also done during those times to even to go for intradural location of these tumors. Vertebral artery handling was, Lulligam Shaker during those years was very prominent in demonstrating extreme lateral exposures. And I was with him during those days when I was with him in 1988 when he described this exposure. Involved exposure, displacement, mobilization of vertebral artery, and removal of condyle. And this was my exposure, which I described in 1995, just small supracondylar infrajugular bulb keyhole approach for these tumors. But then, and also I badly criticized transoral approach for intradural tumors, which was published during those times by Alan Crockett. He was also my teacher and a very respected teacher, but I wrote that transoral surgery is not a good operation. So what I described in the year 2001 was a conventional midline posterior fossa approach. You see, conventional midline posterior fossa approach, I did foramen magnum removal, no mobilization of the vertebral artery, no drilling of the condyle, elevation of the cerebellum, and removing the nerve tumor between the nerves. So I have got now several cases during my journey with middle fossa approach for any kind of foramen magnum tumor located anteriorly. No need for coming anteriorly or laterally. Come from even midline is possible, and for me it is the best. The bottom line is you have to know how to learn to demolish these tumors, which are not they are difficult and dangerous, but if you know if you learn the process of breaking into the tumor, you can do these tumors in a quick, rapid time and safely. So this is my exposure. No condylar removal. Vertebral artery is exposed here, and the tumor here is then exposed between the nerves. And even I reported recently that ossified tumors in the anterior foramen magnum tumors. This is a bony tumor. You see complete bone encasing the vertebral artery on this side, and you see the ragged edges, and this tumor was removed. And this is another tumor, completely solid, crystal-like tumor. You see CT scan, it is hard like rock and bone, and both vertebral arteries are within the tumor. You can see this. So working, and I did from conventional midline posterior fossa approach. This is another tumor like a rock, complete solid, and right in front of the brainstem. And I did this by conventional midline approach. So several of these tumors. Then I want to show you, of course, many of you have seen and heard me talking about third nerve neurinoma, and I have said that third nerve neurinoma is between the dura, arises in the oculomotor cistern here, and then as it grows, it opens up the dural it widens, it is covered by dura, and you can have an interdural approach. This is a magical approach. If you know this anatomy, you don't need orbitozygomatic osteotomy or anything. You can do subtemporal exposure, minimum exposure, break into the, just don't remove this capsule. It is not a capsule, this is dura. Know how to demolish the tumor, and you can preserve the third nerve after surgery. So that is the beauty. If you know that the dura is, dura is going to be intact, and avoid the journey of the third nerve, identify the third nerve early in the operation, break the tumor without coagulation, and you can easily, not easily, but you can do a good job. Even seventh nerve tumor, we have described that these tumors arise from the geniculate ganglion, and they remain within the dura. If you know that they are within the dura, you can remove these tumors in quite a good and quick time, maybe half an hour. Break the tumor, avoid the journey of the seventh nerve in the vicinity, and retain the dura. If you demolish the dura, then of course the seventh nerve can never, I'm not saying you can save the seventh nerve in facial nerve schwannoma, but you can actually attempt and preserve the region of the seventh nerve. Lower cranial nerve neurinomas are also interdural in location. So these tumors are all complete, entire tumor is interdural. And if you have this concept, you can, of course, for lower cranial nerve neuronoma, you have to do infralabyrinthine mastectomy, have to expose the extracranial part, but entire thing is within the dura. And that strategy, interdural surgical strategy, is the key for lower cranial nerve schwannoma. You see this lower cranial nerve schwannoma, and these tumors completely arise within the jugular foramen and then blast like that, retaining the dural cover here, retaining the dural cover here, and you can do a good job and save, not save, but improve the lower cranial nerve function. So this is the tumor, lower cranial nerve tumor, and this is the dura which is preserved around the tumor. Quick word about chordomas. Is a very big, fantastic material for a skull-based surgeon, and I have gone, my journey with chordomas has been very long, more than 30 years at least, or maybe 35 years journey with chordomas. And I used to do very heavy exposures, lot of exposure. But as I realized, as even Borba has said, that these tumors are soft and you can make space for itself. More important is they are bone devastating tumor, but displace the soft tissue. They displace the carotid artery anteriorly, displace the cavernous sinus superiorly. Extradural tumor. For extradural tumor, extradural exposure, you can remove by transnasal exposure also these tumors, but my preference for majority of these tumors, I have still recommend transnasal approach, but for majority of these tumors, I come lateral because the carotid artery is anterior, dura is behind, the trigeminal nerve and gastrodental ganglion is up. So in the year 1995, we described middle fossa subgastrodental ganglion approach to these tumors. And carotid artery relationship is a crucial thing, where we said that the dura is intact in these and cavernous sinus is displaced. So this is cavernous sinus displaced anteriorly. You have heard me talking about this. And petrous apex is destroyed. More important is, one is to remove the soft tissue, and the second is to demolish the bone, which is very important. And there can be small islands of tumor within the bone that you have to drill and you have to remove. But these tumors, if you know that the dura is going to be intact, carotid is going to be displaced anteriorly, you debulk the tumor. That is a very quick removal of these tumors. And then you decide on the clivus how much you have to remove and how much you don't have to remove. Recently, I described an alternative option for very, you see, supracerebellar approach for clival chordoma. I'm not sure if Luis will like it, but this I have used in very selected cases, 5 selected cases. Just let me show you. For this tumor of lateral approach, I have been using, I have described middle fossa subgastrodental ganglion, but for this tumor, because the sixth nerve was intact in this patient, I did a supracerebellar approach, identified the sixth nerve early in the operation, and I realized that the sixth nerve comes like this and then goes on the dome of the tumor. So that is one beautiful thing about the sixth nerve in clivus chordomas. So that's sixth nerve. If you have to save or if you have to preserve, the supracerebellar approach is an option in rare cases. And this is another tumor of clivus chordoma. You see the tumor arise involving the clivus. I did by supracerebellar approach this tumor. This is another tumor quite badly in the posterior fossa. Either you can come from the nose, but at that time, I was very heavily involved in supracerebellar. So I did this tumor by supracerebellar. So that is an option. I'm not saying this is a good option or a bad option, but that is an option. I don't want to talk too much on pituitary tumor, because if I start pituitary tumor talking, nobody in the world can stop me. But pituitary tumor is also a game of dura. We had done this classification long time ago, about 20 years ago, 25 years ago, that the dura of the diaphragm is elevated by the tumor. Dura of the diaphragm is elevated by the tumor. And my feeling is, and I'm absolutely convinced that this concept that the dura of diaphragm is elevated has completely revolutionized pituitary tumor surgery. So diaphragm is elevated, and this is subdiaphragmatic tumor, and this cavernous sinus lateral wall is intact. Roof of cavernous sinus is elevated. So dura is intact. This was also first time in the literature that we mentioned grade 3 tumors, and rarely they could transgress the diaphragm and encase the arteries. So these tumors, if you know the dural confines, you can remove this tumor by transnasal approach. No need to do cesarean section for pituitary tumors. And there are several articles of mine, and this article shows about the diaphragm celli and its complete revolution in the pituitary tumor surgery. So many of these tumors I have done in very quick time by nasal route. Here I will not recommend transcranial route. Like I recommend for tuberculum celli meningioma, I recommend for olfactory groove. I say those who do olfactory groove meningioma from the nose, they are not doing correct. Those who are doing tuberculum celli are not doing correct. And now I say those who are doing pituitary tumors from transcranial are not doing correct. They have to do it from the nose, whether you use microscope or endoscope. That is a very minor situation. And this is also a case for endoscopic or transnasal surgery and not for cranial surgery. Don't remove the planum spinalis tuberculum celli, just anterior wall, break into the tumor. And this tumor I did in 1997. This tumor I did in 2001. This is the simplest of all tumors to be removed. This is another tumor I did in 1999, 21 years ago. You see this tumor, small exposure. And as I said, and this is another tumor I did by the nose. Essentially, if you know the dural anatomy, you can do many of these tumors quickly. C2 neurinomas is also a game of dura, and we described that this is intradural and this is interdural, but later we described in 2018 that the entire thing is interdural in nature. And if I'm not sure if you will like to believe that many of these tumors I can remove in 15 minutes if I know how to open the dura. Acoustic tumor is my most favorite subject, and I don't want to discuss it now because it is a lifetime of experience and lifetime of work and life journey. Epidermoid tumors are another fantastic tumors, which I described. Supracerebellar approach is a beautiful approach to remove. And according to me, if you use any other approach, is not a good option. These tumors are tentorial-based tumors I described in 1996, in 2006, 96 cases. But now I have got several cases of tentorium-based, which changed the nomenclature. Paranasal sinuses are different tumor. This is a nasopharyngeal angiofibroma. I described transcranial approach to remove in 2004, but now I say these tumors have to be removed by transnasal or midfacial degloving operation. So thank you very much, my dear friends. I hope you enjoyed my journey with these tumors, and I hope there are some messages for you for the younger people. Let me just unshare. Yes.
Thank you,
Thank you,
Atul.
Professor Goel.
So, many of these things I have already talked about. Many of the Indian participants have heard this. But, this is to summarize my journey and summarize how I have changed. my thought process on various tumors. And on the basis, you see, the most important thing is I have been able to get several cases in my public hospital. Like even Vernon is in a public hospital. He cannot leave that hospital because my gun is on his head. I have told him never to leave JJ Hospital, which is such a wonderful hospital, such a great hospital. Vernon, only in these
Yes.
kind of hospitals we can improve and we can change.
Correct.
And my feeling is we can completely change the face of neurosurgery by our experience. Thank you very much, my dear friends.
Thank you.
Louis, you say something nice.
No. We need one book of each pathology, One book epidermoid, one book tuberculum meningioma, man, wonderful.
Thank you.
And this idea of the pituitary,
Yes.
I discussed one day with Dr. Oliveira. He had said that it was intradural. It's the diaphragm, because this you go from the nose and the tumor come down.
Yes.
Let me ask you something. But when there is one small piece that's coming lateral, like outside, in this situation, you do transcranial or always coming from the nose?
Many of these cases can be removed from the nose and should be removed from the nose because they are intradural, they are under the dura. And you can work your way because many of the pituitary tumors are very soft tumors. And you can go in this direction, lateral direction, and get into the cavernous sinus and remove this tumor from the nose. I will not recommend transcranial surgery but in some cases, like in recurrent Cushing disease, for instance, recurrent acromegaly, where the tumor is only in the cavernous sinus, it is very difficult to come from, sometimes it is difficult to come from the nose. In those cases, you can come laterally into I have done transcranial for some very unusual cases. Mike, what do you have to say? Something, Mike?
Yeah, no, I mean, those are both very inspiring talks, and I wish I could sum up all of your knowledge and just fester in it all weekend. But that was amazing. So I had one question for when you're approaching the chordomas. You had some good, interesting approaches, not coming from a transnasal approach. What is your then plan for dealing with the dura and the bony involvement? Do you try to do a wide dural resection when you get to the kind of the anterior part of those chordomas and try to remove and be aggressive as you can, or as long as it comes off the dura, you're okay?
See, most important is these tumors are extradural tumors. That is the critical thing. They are extradural. And the most important, I will say, is to preserve the dura. Dura is normal. Bone is abnormal. These are bony tumors. They arise from the bone. They devastate the bone. As Louis had said, there are islands of the tumor within the clivus, and you have to drill that bone as much as possible. So if you have, many of these tumors come in the sphenoid sinus and they come in the midline, and then I will recommend a midline operation on the nose is a good option for chordoma. I will say it is one good indication for surgery. But when the tumor goes very much laterally into the cavernous sinus, even you see, as I have mentioned, that carotid artery is anterior, cavernous sinus is superior. Lateral exposure is a very beautiful exposure. Under vision, the carotid artery, under vision, the dura, extradural. You can come extradural, and you can have a very beautiful exposure right from behind, and you can do a very good job from the transcranial route also in a number of cases. And I showed you some different approach of supracerebellar. I don't recommend it, but in some selected cases which I have shown, like when the tumor is largely in the posterior cranial fossa, that option can be kept in mind. But there, what you are doing is, what I have seen is the sixth nerve. Nobody in the world has ever shown where is the sixth nerve in clivus chordoma. Nobody has shown. In my article, I have discussed that in the tumors, the sixth nerve leave the companionship of the carotid artery. They leave, and they go posteriorly along the dome of the tumor. And I have shown with some beautiful pictures you will like to see how the sixth nerve is going along the dome along the Gasserian ganglion, underneath the ganglion, inside. So that relationship is very important to understand. And that relationship has never been discussed in the literature. So that is very important. To save the sixth nerve, you remove the chordoma, many times already sixth nerve is gone because of the proximity of the clivus chordoma to the sixth nerve is already gone. But if there is any possibility of recovering of sixth nerve, which is very less common, recovery is very less often in a clivus chordoma, but you have to save the course of the sixth nerve.
Yeah, no, that's great advice. One other question, just professionally, what do you do, especially early on when you have these setbacks, when you do these challenging cases and things don't go well? How do you prevent that from guiding your next surgery and the following surgeries that you do? I feel like we always have this short-term memory, and we always remember how our last few cases did more than when we look at our overall series of cases. Any guidance on that?
One thing, I will even ask Luis to talk about this, but one thing is, you know what, in our journey, in our subject of neurosurgery, even if you are doing a convexity meningioma, even if you are doing a, very simple tumor, you can have a big complication. Even convexity tumors have a possibility of complication. But in this business of skull-based surgery, the possibility of complications is relatively much higher. The attitude, attitude is, and this everybody will say, that we have to learn from our complications and we have to learn our complications. And as we grow senior, as we grow more experienced, our complications will reduce. But complications even will happen in the hands of a senior most person, no matter what. And if the complication happens, you see, we become depressed. When you do acoustic tumor, you damage the facial nerve. And you cannot say, I will never damage the facial nerve. Facial nerve can be damaged. You become depressed. You become depressed to the extent that you cannot eat properly and drink properly for 1 or 2 days or 3 days. But you must remember, the patient has demolished face for all his life. He's finished for his life. His identity is finished. So we have to learn the needs of the patient. We have to know what the patient wants. That is why I say that if we have to leave some tumor on some perforator here and there, we must be happily leaving rather than taking the risk. Like for acoustic tumor, I will give you an example of acoustic tumor. Now my strategy is, for large acoustic tumor, never try to peel the tumor off from the facial nerve. Never do it. And you can never do it successfully. This is my latest philosophy in acoustic tumor, that for large tumors more than 3 centimeters or 4 centimeters, leave some tumor on the facial nerve. And those who say I can remove the tumor completely are saying pathologically wrong. This is my interpretation on the basis of very huge experience. So you remove the tumor completely. You try to remove completely, but always try to see the interest of the patient. That should be the priority in your mind and in your heart and in your technique. Never try to do something to show your technique. And that is what, in the journey of neurosurgery, I have learned. Luis.
I think in neurosurgery, in life, you learn of your own mistakes and go and see again what I did wrong, and try to do the best in the next time. But in neurosurgery, if you stop, you'll not do more. Every day is a challenge day. Every day there is a difficult case. Neurosurgery, a simple disc can be very complicated. See? And it's like when you go to, I like UFC. UFC is fighting, okay? I know. There was a fighter, a Brazilian fighter, his name, let me call here.
While Borba is coming, okay, he's
coming. No. There was a fighter, his name is Anderson Silva. Anderson Silva was the champion during many, many years. And the last year, it was easy to him. He was winning everybody. And he got one guy, much, much worse than him, very young guy, and killed him. Do you know why? Was the easiest to him. But when he was inside of the octagon, he was looking at, I can do whatever I want, anytime. When you do this in surgery, it's happened. It's crazy. Because this in surgery, before surgery, I try to play with everybody. When the surgery starts, okay, now go, now have to concentrate. We change completely our philosophy. And sometimes the people don't understand this. Oh, this guy was just joking. Now he's so serious. Now, shut up here, let's stay concentrate.
Okay,
And
now,
after finish the surgery, you go and relax. Change
yes,
completely your life.
yes. Happiness
This
and
concept,
sadness.
But
yes.
Professor,
Yes, yeah.
If you
Varna, now,
sit, we sleep.
what I will like, before I go again to Mike and to Louis, I will like Vernon to give
yeah,
his philosophy and his thoughts.
yeah,
And then I
think
will like Lakib Tripathi, very senior neurosurgeons of our country, to give their own thoughts and philosophy on how to become a good neurosurgeon in general. Yes, Vernon.
yeah, I think after this type of surgery, what I would differ with Professor Lewis, that it's not that we can go and relax, because the immediate post-op care is the most important thing in these types of surgeries, because these patients don't wake up immediately. They take their time to wake up, and the post-op care means we cannot let our guard down, saying that, oh, I've done a very
Yeah,
good job and now I can
yeah.
relax. So I feel we need
Until you start.
yes, the sleepless nights start after the surgery, till the patient wakes up, till the patient smiles, till the patient can close the eye. So I feel it's not just we do the surgery and that's the end. And of course, you got to keep waiting for that patient to come back with a scan which shows a recurrence or which shows a tumor which can be seen.
Yeah.
So my philosophy is that keep doing your best as to how much you can do, and there is no escape for not knowing your anatomy. You have to know your anatomy. You have to keep practicing on cadavers, and when things are down, you have to pick yourself up back again and then go back to work, because this is our job. So even if you're down, if you have the worst time with the case, you have to pick yourself up, and because there is another case waiting for you. It is not that the cases will stop coming just because one case has gone bad. And this is Professor Goel's philosophy also. You got to pick yourself up and then be ready for the next case. So I think that's my answer to Dr. Michael also.
Yes,
Thank you.
Lucky, you want to say something?
Well, it's very humbling to speak in front of giants like you and Dr. Lewis, of course. We had a wonderful evening, and every time I listen to you, first time I listened to Professor Lewis, and of course Mike is very young, and he nicely, compared his first 25 and last 25 cases. Really appreciate the way you looked at those difficult schwannomas, Mike, and all the best, very best to you. What can I say about Atul? That every time I listen to him, I'm really absolutely floored, and the kind of experience, not only just experience, his handling of the tumors. I have seen, we do together many workshops, and he lets me conduct those workshops. We've done together almost 20 workshops, 10 here, 10 there, Mumbai and Calcutta, and the way he operates on these tumors, it's a magic. That has come from a lot of experience, exposure, and as I said in the beginning, introducing him, somebody like him, somebody Dr. Lewis, like Dr. Lewis, they have their own philosophy of managing these tumors and these patients. We don't manage tumors, we manage patients. And the patients, like both of you said, that they have their own priorities, and they have their life, they have a beautiful face to preserve, they have a hearing to preserve. If it is a musician, musician by profession, he has to be hearing properly. And if he's a beautician, he has to be very beautiful. So living behind tumor and preserving the function, as we all know, is most important for me, for you, for everyone. But it's wonderful to listen to all of you, especially Dr. Lewis. I've heard you today. I really enjoyed your talk and beautiful microsurgical depiction of retrosectomies, and really enjoyed your talks. Thank you very much for a lovely evening. Thank you, Atul.
Mike, you just said parting words.
No, I mean, it's always a learning experience. I think that's what's so exciting about this field is so many people have different ways of doing it and have so much more experience, and every tumor is different. And so every time you hear somebody talk, it's always a great way. And I know I've learned many things today that I'm going to go and kind of implement into my own practice. So I thank you for inviting me and sharing with me all of your guys' knowledges. I appreciate it.
So thank you very much, Louis, my dear friend.
I was
You
learning
are
from you.
older than me. You are older than me.
And look it.
So best wishes. Take care of Corona and take care of yourself. Bye-bye. Bye-bye, Vernon.
Thank you,
Bye-bye,
thank you.
Lucky.
Thank you, Michael.
Mike.
Congratulations. Very
Thank
nice.
you.
Thank you.
It was a wonderful evening.
Thank you. Bye bye.
Thank you.
Thank you.
Bye.
Thank you.
Good night. Okay.
Bye. Ciao.
Bye-bye.